Julian, Nick, can we make a start?
That finance exchange over that meeting across the region, across the West Midlands.
Dave, Andy, can we make a start, please?
Caused by the West Midlands office, because we as Chief Exec have all done that. We're really not sure about
Harry, Patricia, can we start, please?
somebody that's it's not as far as you, that's a good thing. And the Chief Exec is saying we think that somebody in our collective West Midlands office would be really keen listening to our conversations and getting organised, which normally would be a good thing. But on this one,
If there is, I'm not part of it.
Yes, I did see
I
something.
think you have to find people,
yeah.
but not me.
Well, I'm just saying on this one, let's ignore it.
Thank you, that's helpful.
Hello.
Hi, Joe.
So that we can have a little more space.
I wanted to do
Me.
Roger relocated.
Yeah,
Fine.
It's all right there, Darren.
it's on your email, but I just think we go with it because it's basically taking key paragraphs from the last one.
And that email that you nodded,
Yes.
not too much,
No.
in asking for that.
Good afternoon, everyone. Good afternoon. Welcome to this meeting of our Integrated Care Board. As usual, we have a full agenda. So I'd like to start and begin to move through it now. Remarks. Can I make an introduction first, though? I'd like to introduce Trevor Pert. Where is Trevor? Hi, Trevor. Trevor is a long-standing non-executive director of SATH, but has recently been appointed vice chair. You're very welcome, Trevor. Good to see you, and we look forward to working with you in your new capacity. Good to see you. We've got quite a few apologies. Neil Carr. We've got Cathy Riley deputising for him, Ian Chan, Leslie Picton, Sean Davis, Nitty Paul, Rachel Robinson, and I've got a note here to say that Lynn Corley hopes to join via Teams, but may be late. So those are they. Just a couple of introductory remarks, if I may, please. First of all, although Simon will make some comments about this in his report, I just wanted to make a personal thanks, really, gratitude to you all and your organisations and your staff for the really impressive responses to managing urgent and emergency care over the Christmas and New Year period. I don't underestimate the challenges that you faced. Having been in a more frontline post myself for many years in different guises, I get it, and I know how much work went into that. It wasn't all plain sailing, but it was remarkably well organised and smoothly operated very smoothly, really. There were one or two aspects of that which exacerbated the position. Of course, industrial action by doctors meant that some of you and your organisations were not only managing for winter, but you were making sure that rosters were available to provide safe cover, and you were also scheduling and rescheduling hundreds of patients whose care was being dislocated as a result of that. So thank you for that as well. Some good news. I'm pleased to draw attention. I think maybe Kath Riley or Paulie, would you like to tell us about MPUFT's recent CQC visit and the outcome of that?
Our older people's wards were visited and they assessed us on safe caring, and we assessed good on both of those. I was really pleased that some of the earlier work that had been done in our adults of working age ward had been translated well to the older adult ward, and that served us well in that inspection. So that were things around fire training and also our restricted items policies, which obviously are really important on mental health wards.
So well done. Congratulations. I also wanted just to draw attention to a very valuable piece of work, publication, I think by Health Watch Shropshire, but it's about GP appointments for Shropshire, Telford and Wrekin. It contains a stack of data which has been taken from that which is available locally, regionally and nationally, and is an important addition to our understanding about the pressures faced by general practice in terms of appointments. And Gareth, where is Gareth? I think you're tasked with doing some follow-up work on the GP recovery programme and appointments, etc. You might like to make sure that the Health Watch report is taken into account as part of that.
Yeah, of course, and Telford and Wrekin did something similar that we're playing in the same way as well. So, no problem.
Simon's just whispering to me. Simon, you're going to tell me it was primarily led by Telford and Wrekin. I looked at your web...
If I may clarify,
Yeah.
Health Watch Shropshire have published a report on their own talking about Telford and Wrekin as well as Shropshire. We are not party to that report.
So have you published a report?
Not yet, no.
No, I'm confused. I'm confused because the Shropshire website for Health Watch talks about GP appointments for Shropshire, Telford and Wrekin. I looked at your website and couldn't see any reference to it. Thereby my confusion.
Yes, we haven't published ours yet. We will be doing when
Excellent.
we've waded through all the 9,600 responses, which is going to take some analysis, obviously.
Yeah.
But we're not party to the other report that's been published.
Well, thank you for clarifying that. I thought our arrangements were a bit complicated at times, but again, it'll be a valuable contribution to the debate, and you'll make sure, Gareth, that that's taken into account as well.
We did a useful accidental joint presentation at the Telford and Wrekin Health and Wellbeing Board jointly, was it 2 weeks ago now? 3 weeks ago? On that agenda, we'll do the same with Shropshire as well.
Okay, that's great. Thank you very much indeed, and thanks for that clarification, Simon. The last thing I just wanted to mention is the ICB offices are in the process of moving. There are packing crates galore, I understand, in Halesfield, and the new office in Wellington starts to be open from next week, and I'm told reliably the bulk of the services currently provided from Halesfield will be operational from there in mid-February. So please don't meander towards Halesfield expecting to see any executives and other people, because from the end of this week they won't be there. They won't be there. So moving on, declaration of interests. I don't have any suggested changes to the register. Are you happy with that? The minutes of the previous meeting have been circulated. Are you happy with their accuracy? Katrina.
Just one question with regards to the winter plan. Did we approve it, or did we refer it to the Urgent and Emergency Care Board for
That's what we did.
further work?
That's my recollection, is that that's what we did, and I thought that's what the minutes said.
No, the minutes say the board approved. The board approved the 23-24 winter plan, including
I think we noted the progress and the work that was underway, and I think we remitted it to the Urgent and Emergency Care Board. Yeah.
Okay, thank you. Thank you for that.
Thank you.
So we'll correct the minutes on that point, Chair.
Yeah, we'll certainly do that. Thank you very much indeed. Moving forward, if I may, if you're happy with the accuracy, there are 2 or 3 matters arising and the action list that I wanted just to draw to attention. According to the action list, Nick White, we're meant to be having an overview on the digital strategy at this meeting.
That was scheduled at last meeting for the March board meeting.
Right, so this action list is incorrect then, so March. That's helpful, thank you. And I just wanted to ask a question. We've had a brief discussion about the rural racism report, and we said we'd add it to the forward plan. I just wondered, is there a guardian of the forward plan in our midst? Do we have any ideas about when that might appear for discussion?
There was a suggestion that it would be brought to the next board development session in February
That's what
for
I
a
thought.
much wider discussion.
So is that still the intention as far as we know? I know that
It is subject to the clash of meetings, Chair.
Yeah, I know that there's a number of the chairs won't be there because there is a Richard Meddings, chair of NHS England, meeting of all chairs in London that day. My inclination is, if the chairs will forgive me, that we proceed with the development session in February as planned. But if there's strong views contrary to that, then please let me know. Okay. So, Gareth, we were promised. The action list says we're going to have an update on primary care access at a future board meeting, and then it says January.
Yeah, so you'll recall that this was presented at the last board meeting.
I do.
I think it was 9 to 12 months down the line that we would come back with the report on where we got to with progress against the metrics rather than an immediate update because the work is still being implemented.
So when do you think we can have a further discussion and review about that?
So I think within 6 months we'll have the indications
Okay.
of the impact of those. I
Okay.
think a full annual cycle would be helpful.
I mean, given the interest in this, given the 2 Health Watch reports and all of the other work that's taking place in this area, the improvement plan, etc., would you and the Chief Executive just like to think about whether there's opportunities to give us an update before then?
Yeah, it comes through Quality and Performance Committee as well, but we can definitely do it.
Yeah, indeed.
Yeah.
That's really helpful. Thank you. And the final thing I wanted to...
Chair,
Do you mind if I...
I'm sorry.
It's fine. I just wanted to say, I think because of the air conditioning and probably my poor hearing, it's not always easy to hear people's contributions, so if we could all speak up a bit.
Yeah, maybe make sure we use the microphones, myself included. And well, if that doesn't work, Meredith, let us know. I might be partially to blame about the air conditioning because I was freezing earlier and asked if the heating could be turned on. So apologies for that. The other issue that's on the action list relates to MSK, but we're picking that up in a couple of places later on the agenda. Is there anything else from the action list that anybody wants to raise? Okay. Questions from members of the public. We've had about 30 requests for information, questions that have been raised by one correspondent, and in the time-honoured fashion we'll respond to those within the 3 weeks and we'll report to a subsequent board, the next available board, the questions and the responses. They're too detailed to go into right now. They're all very pertinent, and so that's how I propose we should handle that. Are people happy with that? That's in line with our existing policy. Thank you very much. So, the next item, Vanessa, patient story. Would you like to introduce this? And we've got Sean Brooks.
Yeah, we have.
Hi,
He's
Sean.
here. Yeah.
Welcome. Would you like to introduce yourself?
Shall I?
Or
Do you
would
want me
you-
to
what-
just
you-
introduce the piece
you
so
take
people know
over.
what they're
Yeah.
expecting? So thank you, Chair. So I'd like to introduce Sian Brooks. Sian was the neonatal lead nurse at Hope House Hospice at the time of the patient story and worked very closely with this family, was part of the team there. She's since moved on, still working for hospice, but as pathway manager. And she's accompanied by Alison Massey, who works with the ICB. Alison's Transformation and System Commissioning Partner and has the lead for palliative and end-of-life care. So the story you're about to hear really shows a positive piece of work in a very sad scenario, but with taking health inequalities into consideration, and so shows how we can in a real life scenario enact that responsibility, but also the really valuable work of the independent sector and the hospice, and how lucky we are really to have a children's hospice on our patch, because not everybody does. So palliative and end-of-life care has generally been on an improvement journey over the last 2 years and done really well to move from a system report that had some criticism to a much better place. There's an adult strategy in place and a children's one that's in development. And with that, I'll hand over to Sean.
Sean, the floor is yours. You probably need a microphone, actually.
Yeah. That's it.
Hold it. Will it come out? I can bring a chair. Oh, is that better?
Yes.
That's good. Yeah.
Okay, so this is a case study where I was obviously involved with a particular family, and we were able to meet the family's needs, and despite the obstacles and challenges that we faced, we were able to ensure that we offered them an equitable access to Hope House Children's Hospices services. So to give you a bit of background, this was a premature baby born at 28 weeks gestation. The little one was born at their local maternity hospital and transferred out to the tertiary centre for ongoing care. The little one then moved between the women's hospital in this particular city and the children's hospital for ongoing treatment and care in the first few weeks of life before being transferred back to their local neonatal unit for ongoing care. The baby was actually referred to us from the local neonatal unit at 6 weeks of age. There was an antenatal diagnosis of these complex conditions, so the baby and family could have been referred antenatally, but they weren't. But the reason we got the referral from the local unit is that we have been building really good links with local neonatal units, spending a lot of time going in and out of the units, raising the profile of the hospice, so that people are aware of what services we can offer for families. So it was a really good opportunity to show how much groundwork had paid off, that the hospital knew what we did, and then contacted us and said, please would we go over and meet with this family and see how we could support them, working together with the neonatal unit, because this baby was going to be in hospital for some time. So I attended the neonatal unit, and for this family it was apparent very quickly that this was going to be incredibly challenging. Not only was their baby possibly not going to survive, but they didn't speak a word of English. The whole situation was terrifying for them. There was not a lot of trust in professionals from this family. So when I arrived and first met with Mum, we accessed the interpreting service used by the hospital, which was over the telephone, which didn't feel very comfortable. It's much easier face to face, but that's the system they had in place for ad hoc interpreting services. I spent about 2.5 hours with this mum, with this interpreter service over the phone, and it took a long time to gain her trust, for her to believe what we were saying. She didn't want to be referred to the hospice because she felt if she signed on the dotted line, we'd then remove her baby from her and she'd never see her baby again and would have no say in the care that this baby received. So there was a lot of gentle conversations, reassurance what the hospice was offering and how we might be able to work alongside them and the neonatal unit that the baby was in. During this time, this period of time was over many weeks that we visited this hospital on a weekly basis to visit the family. Mum was predominantly there on her own, as Dad was looking after their other children or working. We accessed sometimes face-to-face interpreters, which was much easier for this family. And during one of those sessions, I noted how much better the communication was with one particular interpreter and this family, how much more effective it was and how much more relaxed the communication was. So I took the opportunity to talk to that interpreter and explore, how they were managing so much better than other interpreters we'd met. And this lady was able to give me some background on this family, that they were a Roma family. They probably were not able to, within their home country, access the same education as others. So their understanding of the complexities was probably much more challenging for them. Also, dialect, that actually one language isn't exactly the same depending on where you're from. So she'd worked with a lot of Roma families, and she was able to communicate so effectively with this family just by using her previous experience. So where possible, we did use that same interpreter time and time again. Unfortunately, because of the complexities of his condition, there was nothing that could be offered in the long term, and he was requiring respiratory support, and that was something that wouldn't be sustainable, and he would never be able to leave hospital without that. So over lots of time and conversations, it was decided to reorientate his care and remove the breathing support. We weren't sure how long he would live for following that, and conversations were around whether he would come to the hospice or whether he would stay nearer to home. They were an hour and a quarter probably from their home to the hospice, so it was decided he would stay locally because then their siblings and Dad could stay at home and to and fro. So he actually died in the neonatal unit in their local hospital a few days after withdrawing that respiratory support. And at that point, I felt that perhaps we had reached the end of the road with this particular family, because their baby had died. Communication was, really challenging and really difficult. But our normal service is to offer bereavement support for any families that are accessing the hospice at any level. So we approached the hospital while the family was still in there, having lost their little baby, and said, is is that something they would like? Would they like bereavement support? And the answer was yes. At which point I was like, I don't know how I'm going to actually do this. How am I going to offer a service to this family that's equitable, that looks like the service we offer to all our other families who are English speaking? And at this point it would have been easy to just assume that they wouldn't want bereavement support because they wouldn't get so much from it, but it was important that we made that offer. So how we were going to make that meaningful and effective, we weren't really sure, but they'd said yes, so we arranged to go and meet the family at home. We set up an interpreting service account with the hospice so that we could access. We used the same one that I was familiar with from the hospital, so we knew how that would work. So from there, we started doing home visits for this family. Now often bereavement support is very, not necessarily always a lot of talking, there can be a lot of listening, but it was really challenging with using the interpreting service. It was all over the phone. Sometimes the line wasn't great. Communication, again, depending on which interpreter we had. Sometimes the parents weren't being understood. They weren't understanding the interpreter. So it was clunky, it wasn't easy, but we were there and we were offering support to this family. On the very first visit, the family were incredibly distressed when we were there because seeing us reminded them of their time in hospital and their baby. And they were actually so distressed, I didn't think that they would want us to come back again. But at the end of our visit, we offered a return visit if it was something that they would like. And it was an absolutely resounding yes, please. They wanted us back there and they wanted us as often as we would go. So we arranged monthly visits, and over time the visits became more and more relaxed. The families were less distressed when we visited, and they were able to share lots of photographs and memories, and it started to turn into a slightly more positive recollection for them of the time they did have with their baby. And an important point that they made to us is that we were the only people that knew their baby in life that they then had contact with, because the hospital, obviously their time had ended with the team they had around them in hospital. They didn't have any family in this country. They were quite isolated within their community because their language barrier prevented them from, there's normal socialisations and accessing support groups that others might. So they viewed our visits as incredibly helpful and supportive. So they continued monthly face-to-face visits. During that time, we accessed the social work teams and sibling support teams to give a holistic package of whatever they needed support with. And they accessed those and really did use them quite a lot. The next significant event in the calendar for this family was the remembrance service that the hospice holds every year, and that's a service where any bereaved family that's known to the hospice is invited back to the hospice to attend a remembrance service. I was particularly keen that this family would be offered the opportunity to attend this service, but again, didn't really quite know how we were going to make this happen and be meaningful for them. So we looked at what support we'd need to put in place to enable this to happen. We planned our home visits so that we were able to give them small amounts of information rather than overloading them, and to then go back and recheck that they had understood what we were inviting them to, what it consisted of, what it would look like, and what their choices might be. We send letters to all families explaining, but we actually were able to go through that with the interpreter and confirm that the family understood our offer. They needed transport. They live an hour and a quarter away from the hospice. They couldn't access public transport because they couldn't communicate. They couldn't make themselves understood if they needed to change a train or where to get. So we realised the only way to help this family would be to go and collect them. So the hospice arranged some of their team members to go and collect mum, dad and the 3 siblings to bring them over for the remembrance event. One of the really important factors for me in this was the interpreter that we would need to enable them to actually understand what was being said at the service and for them to get the most out of this event. And also, if they were distressed, we wouldn't be able to communicate with them, so it was essential we had an interpreter. And at that point, to me, it was clear that we needed the interpreter that had been really successful for this family in the hospital. So I contacted the interpreting service and asked for this lady by name, but there was hundreds of people with the same first name, and that's the only information we had. So I went back to the referring hospital and asked them if they wouldn't mind trawling through their emails and bookings to see if they could get any more information, which they very kindly did. So we were able to identify the interpreter. And then I was able to actually communicate and chat with her ahead of the event, because it's not something that everyone would feel comfortable attending or presenting at. She was absolutely delighted that we had approached her, because she felt that she was able to work well with this family and was very happy to attend the service. So she arrived ahead of the family. We were able to do a run through of what the day was going to look like, so that by the time the family arrived, she was able to support them throughout the whole of that day. Nobody's told me I haven't been moving on with it. Once I get on a roll, that's it. So the impact of this was absolutely huge, and I think the words that the family were using to feedback, such as exceptional, grateful, support, heartwarming, and the fact that they were viewing the hospice team as family to them, because we were the nearest thing that they had to family in this country. But I think also the impact for staff, that actually it's important that we look outside the box. It's important that, you know, anything can be possible. It might not look like the service that we offer to somebody else, or it might be done slightly differently, but one size doesn't fit all, and it needs to be a bespoke service to meet those individual, unique families' needs. And I think, you know, it was absolutely a great opportunity for us, I think, as a hospice, as a team, to see how well we can actually support families, and it doesn't have to look like the last family we supported. And I think this is loads of words, so I am going to read it out. I'm sorry there's loads of words on there, but I think it's incredibly important that I do read this to you. This is feedback we had via the interpreter from the family. She spent hours with that family that day, and she wanted to share all of this with us, so I'll share it with you. So the interpreter said she'd like to thank you for having me there and giving me the opportunity to be part of such an amazing event. As I've already mentioned, it was a very well organised day from beginning to end. Your premises were presented beautifully, and what you do for all those families is incredible. The baby's family was exceptionally pleased to be there. Throughout the day, they shared with me several compliments and expressed their gratitudes towards the staff and the support that they've received from all of you. They said that they've never been treated like this, never been invited to any sort of event, and never received any support like this. And that was due to the family's Gypsy Roma background. They were often discriminated against, targeted, and turned down. This is the very first time they've experienced such warm and loving support from professionals. The dad kept talking about the beautiful scenery and how he could imagine if the baby would still be with us, they would play outside in this beautiful location. Both of the parents shared that they were so happy to have such lovely people around them. They had an amazing time there. They loved the service. The children enjoyed themselves as they had plenty of activities, food, drink and snacks available for them. They were also very impressed when the staff offered to wash and dry their daughter's clothes as she was sick in the car on the way there. Both parents and baby's siblings wrote lovely messages for him, and they loved the spirituality of it. The mum was grateful for all the heartwarming support from yourself and other staff when she became emotional. The family are really looking forward to next year when the service happens again. And I don't think I've ever come across a family that said they're looking forward to coming back to the service, but it obviously meant so much to them that they were included and invited and able to celebrate the short life of their baby. And I think it was only after this event that I realised the huge importance this was. I hadn't realised how discriminated the family had been previously, so I was not aware of any of that, but it makes, in fact, to go goosebumpy thinking about it, the impact on this family was just huge, and it's, you know, we're proud as a hospice that we were able to support this family in that. Thank you.
Thank you very much indeed. Let me throw it open. Vanessa, did you want to add anything?
No, I think just to say that the Children's Palliative and End-of-Life Care Strategy is actually being led by the Chief Executive of the Hospice. So really grateful to Andy Goldsmith for his time and effort in bringing a group together. And also I know he spent a long time on engagement and thinking about an engagement and a co-production approach with families in that development of that. So I'd just like to thank Sian very much for presenting.
Thank you very much indeed. Pauline, you wanted to come in.
Thank you. Thank you, Sian. It's an exceptional story of how we're actually being inclusive. I'm curious around what's changed as a result of the learning from this situation.
Yeah, I think we're much more ready to use interpreting services instead of perhaps trying to manage. We've got it set up now, and we really promote the use of the interpreting service, even for families that do understand English, but actually these are really challenging conversations, and you know, in a second language you can't be certain that you're getting that full understanding. So we're certainly accessing the interpreting service much more, and I think because so many staff were involved in the remembrance service, and I've seen, you know, what we were able to do for one family, I would hope that it would encourage the members of the teams now to actually not be scared away or not offer the same. You know, we can do it, and we've done it, and we've proven that. So I would, you know, hope that all the teams are encouraged to go that extra mile, because we can meet these families' needs.
Thank you. Any other questions or comments that people wish to offer? Vanessa, I was interested in your comment about the development of a strategy, a plan. Just tell us a little more about that, when we might see it, what kind of passage would you expect it to have?
Well, the System Quality Group and the Quality and Performance Committee have kept a close eye on palliative and end-of-life care and had regular updates. Now, I'm going to have to defer to Alison to tell me when we might expect a strategy. I don't know where.
We already have the adult strategy, which is in the second year of implementation. So the children and young person strategy had a little bit of a bump, because what we wanted to be able to do right was that engagement piece. So we've worked for a very long time just to get to understand what is the right way we can engage with not just families but children and young people with life-limited, life-threatening conditions. We were very aware of these motive subjects, and we needed a bit of specialist support for that. So really grateful from the ICB's engagement team for supporting the children and young persons working group to get that strategy together. But we want that feedback and understanding of what our children and young people and families want from those services.
Thank you.
We were expecting a strategy by the end of this year, but we're going to be probably looking at a first draft by the end of this financial year for consultation over the next quarter. So it will be very soon within the new financial year.
Okay, thank you. I was just thinking, looking towards our schedulers again, if we can actually think about how and when we might have the opportunity to discuss both of the strategies together, and have a thorough debate about it, and excuse me, and our views about priorities and the way forward. That'd be hugely helpful. But that's a great contribution, and thank you very much indeed for all of the work that you and your colleagues do, and for your presentation today. Fantastic. Thank you very much indeed. Thank you. Okay, moving on. The next item is emergency planning, resilience and response. And I see your names against it, Simon, but I also see Sam Tilley's sitting in the audience, as it were. How do you want to play this?
So I'll do a very brief intro and then hand across to Sam, if that's okay, Chair. So take the paper as read. Just to reinforce to board colleagues, the ICB as a board, we've got two responsibilities. We've got the responsibility to look at the ICB's ability to respond to emergency responses, incidents, as a type 1, category 1 responder, but also has the responsibility to have the oversight of our provider responses as well in that space. The paper sets this out, demonstrates that we're in a challenging position across the system against the core competencies in this space, but also then proposes some steps to take that forward, and would value the conversation in terms of getting into that discussion, that debate in terms of next steps. But ask Sam to put the detail around that and go through the paper in more detail.
Thanks, Sam. Sam?
I think, as Simon's explained, the paper, I hope you'll find, is a comprehensive...
I can't hear.
Is my microphone not working? Is that better? Oh,
yes.
Yep.
Okay, let's start again. So just building on what Simon has said, the paper, I hope you'll find, sets out a comprehensive description of the work that's been undertaken over the last period. It follows the reporting requirements that we need to undertake. So not only does it set out the position in terms of our annual core standards assessment by NHS England and the role that we play across the system in that, but it also sets out our participation within the Local Health Resilience Forum and the partners that are involved in that, our training and exercising across the period, occurrence of incidents, but also importantly the lessons learned from that, so that it takes through that information to meet our reporting requirements. So I hope what you'll pick up from the paper is that there's been an extensive amount of work that's been undertaken. I think what it then goes on to look at in a little bit more detail is the annual assessment process, and as Simon has described, the role that the ICB takes not only in discharging its own duties but also in assurance around the system responsibilities for individual partners. So as you will have picked up from the paper, we have experienced some challenges around this year, and I think the outcome of the assessment for all parties in the system has not been what we would have hoped. So what the paper then tries to do is look at the improvement work that we need to put in place, taking account of some of the particular challenges that we've had in this period, and how we're going to move forward from that. Clearly, there is a lot of work that we can do jointly, so we're now looking at how we can work across agencies to use our limited resource most effectively, but also looking at how we resource the requirement so that we have in place resilient arrangements to do that. I think it's also fair to say that the agenda has grown significantly since the ICB came into being and took on Category 1 responsibilities. If we just think about some of the topics that might be included in this agenda, so looking at our cyber resilience, looking at how we might deal with mass casualty events, looking at flooding, which is a particular issue for us in the county and now is becoming a much more regular occurrence and is evolving as an issue. These are no small matters, and the work that needs to go on in the background to support the systems and processes, the training, the practicing, how we might respond to these things is really quite complex and extensive work. So in moving into new territory as an ICB, relatively speaking, around emergency planning, now's a good time for us to look at how we might resource this in a more resilient way going forward, and I think that will really support the improvement work that we need to do, not only as an ICB but also as a system, given that responding to these events is rarely done in isolation as an organisation. So I'll leave it there.
Okay, thanks
questions.
Simon, thank you Sam. Let me throw it open. I'd be interested in the views of some of our non-execs and provider colleagues about the scores and the issues that lie behind them. I'm going to be fairly random here, I suppose, but let me ask Roger Dunshea first of all, if I may, if you've got any thoughts about this and what you think of it.
Thanks. Yes, we discussed this at the Audit Committee on the 17th of January, and we had a good discussion with Sam about the reasoning behind the non-compliance status across the piece, and that we were given some indication that steps were in hand to rectify some of the concerns, and we asked for I think it was a report in 4 weeks' time, just to give the Audit Committee an update as to what progress has been achieved. So I think the Audit Committee is now taking on this responsibility to assess the progress across the various provider organisations, and Sam will report back to us as to where the major sticking points will occur. Thank you.
Thank you. And looking at it, my heart lifted when I looked at the first table in terms of core standards assessment outcome, with SATH sitting at 86% fully compliant, but sank a little when I saw the next table and showed a reduction in compliance, a significant reduction in compliance. So Louise, tell us about that, and and the kind of reasons for it and the lessons to be learned from that?
Thank you. Yes, I think the report points to some of the issues in 4.4 regarding the process. I know there was a number of actions in train, but until completed, those wouldn't be taken into account. So there is a set of work programmes in place in order to strengthen this. We're cited on those. And similarly, we have reports going to our Quality and Safety Committee and our Audit Committee on this. I think there were some differences, if I've understood it correctly, between expectations against each of those, but it's still an extremely important area. It's right that we aim to have improved compliance, and there are plans in place to achieve that, and I'm confident there are some actions already in train to do that.
Thank you very much indeed. And the other area my eyes alighted was the ICB itself, with the 17% reduction in the compliance score. Who from the ICB wants to comment on the reasons for that and remedial steps that we need to take?
So I'll comment on that, Chair. So similar to the point that Louise has made in terms of the timing, process, some of the work that's taken place, some of the deadlines that have been missed in terms of that. You'll see in the paper that I've also set out that I've commissioned a review from NHS England, and that's completed, or certainly well underway. That's reporting directly to me. That will give me a set of actions for implementation, part to support the shaping of the future structure of the EPRR response in the ICB as we go through our management of change, but also to make sure that we've got a really clear oversight of action plan that can be implemented across the organisation in terms of improving our position going forward. So already taken a number of actions to improve on that, but equally that independent review will be really key from a Chief Exec's perspective to give me the oversight and the action plan to put in place.
That's great. Thank you for that, Simon. And well done, Shropcom and Robert Jones, who seem to offer a pretty high level of compliance. Any particular lessons, Patricia, you want to share with us about that?
We recently took on an EPPR person called Brian McMillan, who's been fantastic, very skilled. But I think his approach and style has been to work with service managers, lead managers and lead clinicians. And this is no mean feat for us because we haven't just got one building, we've got over 76 buildings, not least all of the services that we provide within people's homes, kit, etc., being able to get across the county, as Sam says, in some challenging circumstances amidst flooding and plague and various other things that hit Shropshire, Telford and Wrekin. So I think there is having some skilled people that can work with key champions across our trust, clinicians and senior managers, so that we can have in place good business continuity plans, because thankfully we don't often hit on major incidents, but often things go wrong, where having good, strong business continuity plans that are tested regularly means that we can respond appropriately. So having that expertise, and I think there's more that we can do across the system in terms of sharing expertise, but there's no mean feat in terms of organisations that cut across such a geography of 1,300 square miles, of making sure that you have somebody that can coordinate those activities, have clear champions and embed that learning and keep it updated.
Thank you very much indeed. So if I come back to you, Roger, because clearly the Audit Committee has been asked to keep an overview of this on behalf of the board. Anything that you want to respond to in terms of that which you've heard this afternoon?
No, as I said earlier, we will get a report middle of Feb. That's 4 weeks since the last meeting of the Audit Committee. And we will assess progress then and identify any major concerns to be escalated.
Okay, and it sounds as if quite a bit of the progress will be about process as opposed to definitive.
And collaboration. I think
that
would be key. I think greater collaboration will improve things.
Thank you. Julian?
I think that was my point. I was going to say this is an area surely that we should have a joint sort of pan provider sort of piece of collaboration, everyone work together. I mean, I think looking at those two tables, for me, it's a sort of a microcosm of our system, really. Overall, we're pretty poor. And then over the years change, you've got Robert Jones and Shropdock who are sort of sticking to themselves, plodding along, doing their own thing, not changing. You've got SAF crashing because it's overwhelmed with the other activity that it's got to do. and you've got the ICB slowly deteriorating, and yet also outside this you've got primary care that's not even mentioned in this, where really the approach to primary care about business continuity is there's no support from the system. We just get a message saying, I hope you've got a business continuity plan, you should have your individual provider. So for me, it flags an area that we should actually be doing this joint across the whole system. Surely it's one area that we need to say we have a combined function for EPRR to actually try and improve these outcomes and improve the position we're in preparation for these events. It is each trust will have its own challenges, and obviously as Patricia, the community trusts have done really well. They're slowly improving as things go on, but that's not mirrored in everyone else. So it's about learning from everyone and working together.
It's a fair challenge, Simon.
Agree, Julian, and we've started those. Agree with the proposal in terms of the collaborative working. Don't agree with the summary of how you categorised organisations and the system, but that's a different thing. Just to be clear, I think the point around the collaboration piece, if we focus on that as a proposal, yes, but again, that requires all partners to want to be in that space and to collaborate there, and we can't do that if we end up with bits of, because we'll end up with an even greater or we run the risk of further fragmentation in there, but that principle of a really strong response as a system with our resource aligned, focused on that and working together is something that absolutely, for me, is part of the NHSE review and as part of the conversations that we've kicked off with system partners.
Okay, and I presume, Sam Tilley, part of the ICB's responsibility is to oversee, coordinate, draw together the respective responses so that there is a system view of this important topic. What I'm not sure about, and I think it's a really interesting point, is the ICB's responsibility in terms of individual practices, etc., which is the point that Julia made, and I don't know whether you've got any comments to make about that. That strikes me as a potential Achilles heel for everybody, not just for us.
Yes, absolutely. I mean, I think there's a number of elements in relation to that. One is that hasn't necessarily formed a core part of our responsibilities in terms of how we're assessed and the guidance. There is a direction of travel towards that, but we're not there yet in terms of NHS England structures. However, that's not to say that it's not an extremely important part of what we need to do. I think what has played out here potentially is the lack of capacity to do everything that we need to do, hence the notion that's woven through the paper in terms of the resourcing requirements that we need, and Simon's obviously alluded to the review, which will help with that. So in terms of going forward, and I think I've mentioned it in the paper, not only primary care, but there's also specialised commissioning, there's the wider primary care, so not just primary GP practices, but also pharmacy, optometry, dental, etc. We need to factor those into our plans going forward, because although there's no formal requirement at the moment, there will be in the future, and as you'll see from the paper, the enormity of the agenda we're struggling to service as it is.
Okay, that's very helpful. So, in summary, we shouldn't forget the ICB's overall responsibility for coordination, but that shouldn't dilute individual organisational responsibilities. We take the point about primary care in the wider sense, specialist commissioning, and you need to keep us up to date and advised about what we need to do and how you think we might go about that. We'll remit to the audit committee under Roger's leadership and the involvement of others about assurance with this process. We look forward to getting a progress report in a month or so, perhaps as an adjunct to the next board papers, just so we can see about the kind of thing. Well, presumably it'll come forward as part of your routine report. So that's really helpful. Thank you, everybody. Dave, did you want to come in?
Yeah, just a question of, in terms of resources, in terms of this taking up resources, I find it difficult to square that with the view of the workforce plan that we are 3,000 over plan, and I'm just wondering how we set priorities if we're over recruiting significantly or having a significant over plan in terms of resources, how this fits into priorities.
Sam?
I think we're talking about resourcing in the wider sense. So you've heard discussions about how we might collaborate better, how we elicit skills and experience and expertise in this particular field, because it is a specialist skill. So we do have a certain amount of capability and capacity and experience within the system across partners. Also, we're now looking at, as I've explained in the paper, how we work with other ICBs, so within our local resilience forum footprint across Hereford and Worcestershire. So it's not necessarily about more people, although that would undoubtedly be helpful. It's also about how we use the skills and expertise that we have access to amongst the partners that within our footprint, but also externally, and NHS England as well, to support that. So there's a complex way of looking at it that's not just about numbers of people, if that helps.
No, yes. But the only thing is that if with 3,000 something over a plan, I don't thought we'd have found space.
3,000 over plan?
Yeah. According to the numbers on the workforce plan that we're looking at later, we would have found some space to actually have those resources. But anyway, we'll come back to that.
Yeah, but the slight problem, of course, that we've had this year is that we're 600 over plan, and what goes alongside that is a huge bill that we can't afford in terms of our deficit. Your point is very well made about the importance of this and giving it due priority. I like Sam's response. I mean, I think it is the right thing to do to look within our existing resources through means of collaboration first and foremost. But if we get to a point where we just can't fulfil our statutory responsibilities, then we need to know, and the assurance that we'd seek through Roger and the Audit Committee, and then we need to have a discussion about how we're going to deal with that. Simon, you wanted to come in, Louise and then Meredith. Simon?
Would it be possible when you've actually looked at what the piece of work that the NHSE has done for you in terms of looking at this, what a predicted timeline might be in order to actually get to a point where we could have confidence that the system can meet its obligations? I think the public has a right to know that, or if you're not going to meet it, that's what you've just said about workforce, what then?
Okay, can I respond to that, Chair? Because I think there's two bits to that Simon. So in terms of timelines and next steps and actions linked to that, absolutely, that will be part of that process. I think let's make sure that we understand an assessment against the core competencies versus the ability of a system to respond to incidents as they arise and the role they play, and often there is a gap between the two. So in terms of the responses that both providers and the ICB have delivered against a number of incidents, nobody's saying that they've been failures or haven't met the requirements of being a Category 1 responder. As ever, there's always things that you can do better and do differently. The response in terms of the core compliance, as both Louise and myself have touched on, set out in 4.4, there's a different need and a different ask in terms of the assessment of those core competencies. Now, clearly we want to do better. No arguments from me in terms of that, but you can't automatically just do a link from that to the provider or ICB's ability to respond to an incident and say one drives the other, but we need to do better in both. But a timeline, yes.
But equally think of it from the public's point of view.
And hence why this is in public, Simon, and why it's talked about and why it's shared on that basis. I just wouldn't want people to make the automatic assumption from an assessment on core competencies across to an organisation's response to an incident that takes place during the year.
Perhaps expand on that then next time.
Yeah, that's fair. That's fair. Yeah, absolutely. Fair point.
Who was next? Louise, I think. Yeah, and then Meredith. And then I need to move us on.
We welcome that as a provider and with other colleagues in bringing our teams together. They do meet together now. There's more we can do, and we're supportive of the work that Simon's referenced. Also, I think in terms of this assessment, it's helpful in highlighting areas of focus. Within each report, there will also be examples of good practice, and I know that's the case for us, it will be the case for colleagues. So we also have the benefit of being able to see tangible examples that have been independently identified that we can draw on to get the strength across the patch. So I feel that the process we have will enable us to do that, and able to contribute to the assurance processes that you've described.
Thank you, Louise. That's very helpful. Meredith?
Thank you very much. It's a very, very important piece of work, and if we don't do it right, then it could very easily blow up in our faces. So I'm very supportive of the work being done. It strikes me that there's some significant expertise in the room that we don't tap into because, as with many of our conversations, it's rather NHS focused. So I just wanted a bit of reassurance that all of our EPRR work is done in conjunction with our local authority colleagues, because they will be doing something similar, but they might be doing it under a different banner or to a different timescale. But if we're not completely joined up with local authorities during an emergency, then that is in itself one of our major risks, I would say.
Nick?
Yeah, I can just pick up on that, Meredith. So as part of working with local authorities, there is a...
Probably need to use your mic.
Sorry, is it working? So I co-chair with Rachel, who's the Shropshire Director of Public Health, Local Health Resilience Partnership, which is how we link in with local authorities, and also we are now moving to doing on a footprint jointly with Hereford and Worcestershire, which is footprint for the Police and Crime Commissioner and Emergency Services. So that does exist.
Okay, an important discussion, and thank you, Sam, for drawing these issues to our attention. I described a bit of process earlier, and let's end the discussion there, bearing in mind we've a lot to do, and we look forward to further discussion about this topic in the near future. Thank
And
you.
the board approves all the recommendations in the paper.
Yeah. Let me just double check that everybody's comfortable with that. Section 11.1, 3 recommendations in particular. You're comfortable with those? You agree them?
Yeah.
Thank you. Next item is the CEO's report. Simon.
Yeah, thanks, Chair. We'll take the paper as read. We'll pull out a couple of high points and areas of challenge from it. So the paper goes through the usual areas on updates and covers a multitude of topics. We still, as we sit here today, haven't had the NHS planning guidance for 24-25. However, let's be really clear, that is not stopping the process of planning and system conversations with providers, with the ICB, with local authorities in terms of working through what that looks like. We've set out really clear timetable that's been agreed, and then there's a set of conversations, confirm and challenge conversations that are happening. Clearly, if the planning guidance is published and that changes things fundamentally, then we'll need to go back around that loop. But for now, I think we've got a strong approach within the system. A clearly understood timeline was discussed at Chief Execs this morning. I think the risk is really clear, though, in terms of balancing, as we talked about, our workforce triangulation, our performance, and our financial position to make sure that we get the balance in place and really clear in terms of what's different in 24-25. You've already touched on, Chair, the UEC performance over the Christmas and New Year period, and would echo that in terms of thanks to colleagues for the work and effort that has gone in and that continues to go in. And I would add in the response in terms of the industrial action piece to that as well, and the impact that's had on staff across organisations. Look, it remains fragile though, and whilst we are grateful and recognise that this year's been an improved position from last year, we've still got patients and residents in areas where they're being cared for that's far from ideal, and would want to be managing that in an even better way going forwards and deliver even further improvements in terms of that. So system partners are committed to continue to work through that, and I'm grateful for Louise chairing the UEC board that's driving that agenda and working through that in terms of the level of detail. I reckon I highlight a number of areas where this year system partners have responded and reacted and engaged differently in a more planned way. That's confidence in terms of the planning process. It's how do we keep building on that whilst we've still got that fragility in place across all providers and across all areas. So, you know, I'm not meaning to miss anyone out there because it's as fragile in terms of some of the UEC in general practice in terms of urgent appointments as it is around other areas. So we've got to get that risk balanced in the right way. There's an update then in terms of the progress being made around integrated neighbourhood teams. So we've talked about the local care programme previously, and we'll have more formal updates on that. But board previously had asked for an update in terms of the work that was progressing. So that sets out some of the positive work that's happening in this area, and you can see that's across the area. There's a lot taking place in terms of Telford and Wrekin, as well as in the rural areas around Shropshire. There's some really joint planning in terms of how we're developing buildings to have joint services in, that's building on that approach towards delivering the local care programme. And including mental health services, general practice, voluntary community sector in that. I've updated on the reshaping of the ICB. Just for clarity, the management of change and the formal process starts on Tuesday, with all staff being notified of then being in a formal process around that management of change, which will deliver that reduction in running costs. And so the structures and the work that sits behind that is really important, of recognising the impact on individuals. We've touched on it already, but the key bit here will be the operating model for the system. What do we mean by provider collaboration, that we're going to talk on later in the agenda? What do we mean by place-based partnerships? The reframing of some of that work, and making sure the ICB is able to discharge its statutory functions, whilst understanding what we spend in terms of running costs, and getting that back to within the budget that we get given, is a really important part of this. But I note the impact on our staff as we go through a really challenging period in terms of the planning and setting up 24-25. We're going to talk later in terms of health inequalities, but the Core 20 Plus ambassadors is a real good news story in there in terms of the number of people that have come forward, but I'll let Liz, Tracy and others expand on that in more detail. We've had quite a lot of GIRFT interventions across the system, which has been positive in the main, not reported in here, but we've also then subsequently had an urgent and emergency care GIRFT visit, but that we're still awaiting that feedback yet formally, so not recorded in here. And then I've updated on progress that's been made in the hospital transformation programme and set that out as well. Happy to take any comments or questions, Chair, on any of those bits or other areas of business.
Thank you, Simon. As ever, your report is packed with information and issues, so let's just spend a few minutes seeing what aspects of it people would like to quiz. Tina.
Thanks, Chair. I think it's only when you see it detailed in your paper, Simon, that we realise the significant achievements that are happening at neighbourhood and at place. I was astounded actually when I saw all the things, that's really good work that's going on, and I think we should celebrate that, because I don't think we celebrate often enough some of the good things that are happening, and that's happening through the local care programme. My question is, and probably not to be answered now, but it would be interesting at a future date to know what impact those things are having.
If I may, Chair. A really important point, Tina, and that's why we felt it was important to put as much detail in this report on this piece, recognising the development session that we had on the local care programme and linking to the inequalities conversation that we're going to have. I think it's now, how can we go further, faster, but make sure that the impact, we're tracking that and it starts to feel differently, because if it's not feeling different both for our staff and for our residents, then actually all of this really good work misses the point, doesn't it? And then that needs to translate even more so into the management of escalation, and I mean that from a resident's perspective, so that we look after people in their own homes as long as we possibly can, and we really then get into that prevention piece. The hospital transformation programme, local care programme, is predicated on that community-based work. This sets out some of the structural things that are happening which are really important. That needs to then build that maturity and get into that bit so that people feel different in that space.
Thank you. Any other questions? Meredith.
Thank you. Just to reiterate Tina's point, I think it looks brilliant, actually, all these developments and initiatives. It'd be nice to see it in more detail, but yeah, absolutely, completely agree. In fact, it's the very list I was hoping we would see one day, and it's actually emerging, so that's wonderful. There's just an expression in here that made me slightly anxious, and I'm sure you can help me, Simon. 3.1, one of the bullets says, that we're unleashing the power of the community and the voluntary sector. And I wondered, unleashing power always sounds like something a politician might say. What does it mean, and what does it look like? And what have we done to unleash that power?
So I could look at politicians sitting around the table and ask if they feel unleashed, and what would that say? Okay, fair comment, Meredith, in terms of highlighting that. So we know in some of these areas, and I look to my voluntary community sector colleagues, and we had some of this conversation at the ICP 10 days ago, last week. There are some areas, Meredith, where we would say this is working genuinely differently than it has previously, where we've got voluntary community sector leading some of these areas and driving that forward, and people want to come in. And there's some areas where we know there is more to do, and how it feels too governed by statutory responsibilities and statutory organisations rather than really engaging the communities in a different way. So I guess what we are saying there, what we are saying there is where we're able to get that right, the difference that's making to how we work in those communities is noticeable and marked, and there is a lot to learn from that, and we need to broaden that and widen that and keep working at it. Perhaps the language could have been slightly more toned down, but actually where it's working really well, I would say that is exactly what is being delivered and is being achieved, but we've got more to go. But I wonder if my colleagues from the voluntary community sector want to build on that just a little bit. I'm not going to ask you the question as to whether you feel unleashed or not, but...
So don't unleash Jackie. Oh, what would that mean? I think you're right in to say that where we get it right, it's made a difference. My pushback would be we get it wrong. No, we don't get it wrong. I think the system gets it wrong more than it gets it right at the minute. It feels it works really well. And at the ICP meeting, it was very much about the Health and Wellbeing Board and how at that local level, working together, we really do make a difference. Yeah. And those recommendations, and it feels very powerful. It doesn't feel like when we get up to this point that we understand that. And there have been, as far as the voluntary sector in Shropshire is concerned, and maybe Louise might say something different in Telford, is that unleashing the power, I think we've got a lot more work to do on getting that right. But when we do get it right, wow. Yeah.
Interesting. There's a comment made, I can't remember who made it, at the Integrated Care Partnership meeting last week about VCSE feeling listened to by the Health and Wellbeing Boards, but being, my word, not the word that was used last week, remote in terms of the ICB. We didn't pay sufficient attention to the kind of issues that you wanted to hear about. And I think, I mean, that was said quite genuinely, and I've been reflecting on that since. I think we've pinpoints Meredith's point, whether it's about power being unleashed or not. For me, illustrated the point about us needing to do more work to make sure there's a mutuality of purpose, an understanding about what we want to do together, and the contribution you want to be able to make. There's a missing link there, and I was just reflecting on this a couple of days ago when we met on the 3rd of October last year. We talked a lot about these things. We had that great event in this very room, I think, or in this very building at least. And I've been in communication with Meredith just today, in fact, about how we re-energise all of that, because I think there's something not quite firing as we would like it to.
Yeah, so I'm in the middle of putting a response to that specifically about trying to get back to how are you going to embed the VCS into the system, that we become, you know, a partner that matters. Mm-hmm. And I think that was the comment we had at the Health and Wellbeing Board, is we like coming there because we make a difference. And it's not about being listened to, it's not about being engaged with, it's about what we do making a difference. and working together. So I know there's something about going back and using the NAVCA quality development tool to rate where we are as a system in embedding the VCSE. And I think if we go back to that, I think that'll start some basic principles on how we do that. So I have got a plan to come forward to do that,
well, please.
as well as just how we can get it right more times than we get it wrong.
Well, I think what would behove us well, and it'll be nearly 6 months since we met.
Yes.
Meet again. Think about the things we talked about. Look at the kind of ideas you've got. Reflect on the kind of comments we've heard around the table today, and decide between us about how we're going to take this important piece of our joint work forward.
Yeah. Be in touch.
Thank you.
Yes. Yeah.
Okay. Now we've got one or two other. I think who was next? Oh, from all quarters. I think Julian was probably next, then Paul, and then Roger.
Some of what I may say may have come up at the ICP meeting. I don't know who was there for primary care, but I wasn't invited as the chair of the GP board, so I'm not sure whether what I'm going to suggest came up at the ICP meeting. But I think my question's about the planning, and it feeds into some of this. I mean, for me, obviously, later on we're going to hear about our financial position, and we're in a very dire financial position. And so I presume most of the planning is really going to be just a continuation of what we've been doing, with a gradual shift in the direction towards more care, the left shift to more care in the community. I suppose my question is how it's too late in this process, but surely as part of the planning there should be a bigger piece of work about how do we reprioritise what we're doing, because we need to invest more money into the VCSE, more money into community-based care, into prevention, and how we can be doing our planning at this stage by inviting what our providers think without having done that piece of work to say actually where do we want to spend our money is a challenge. I do hear, I think, and it'd be good at a later meeting to talk more about it, a lot of criticism about GP access, whereas GPs are working, primary care is working at capacity, it's working on or under budget, and it's not, primary care is not responsible for the majority of or any of the overspend within the system directly. We're seeing primary care being asked to do more and more, yet we're seeing sort of an unwillingness to commit more into primary care that's above what's required through the statutory sort of GMS, PCN based funding, without an ability to increase the LCS, locally commissioned service funding. And I noticed one of the comments in 1.3 is that there's going to be discussions with providers about what their demands are or their asks are around activity and finance moving forward. But I'm not sure there's been, I don't know who's championing primary care and saying, well, if you want more access in primary care, you need to pay for more access in primary care, and where is that challenge and that discussion coming? So I feel I can understand why we're doing the planning, and we haven't got the NHS guidance for next year. We haven't got there is a new GP contract starting on the 1st of April. We have no idea what's in that. In theory, the press is saying it's a contract that's really a holding position for a year before a new contract in 2025. But I think there is a need to invest in primary care in the VCSE out of hospital, and somehow we can only do that by moving some of the money around in the system. And I can't see how we can do that at the moment with the severe challenges that are being faced in the acute providers and our other providers. So it's without having an open discussion about how we prioritise and how we transform our areas of spend, I don't see how we can transform our spend in a proper way.
Yeah, I think it's first of all, in terms of the membership of the Integrated Care Partnership, its membership and the requirements of membership, I must confess, are a bit of a mystery to me, but it doesn't include providers, and therefore doesn't include GPs either. And I think that probably, I can't speak for the joint chairs because they're not here. I think there might be some reluctance to open the membership of that group, but it's certainly something that perhaps we need to just bear in mind. Your point about prioritising and making sure that we can direct funding into the areas that will make a difference and set a different tone and style of how we deliver is a discussion that I and the Neds have been having with Simon and Claire on a regular basis, and Claire might want to respond about how you think that might be taken forward in this very tight, difficult financial position. I mean, let's be clear. The notion of just producing another plan that's an incremental difference on this year and previous years won't cut the mustard. We're going to have to be seriously different, seriously radical, very focused on our priorities. We're going to have to think critically about some of the things we do that we might not believe we can continue to do. I mean, it's a very difficult scenario, and I know that the executive team and chief executives agree with this. I think we've got some really difficult, challenging, but actually exciting opportunities if we're brave enough to take things forward in a different way. Now, how that unfolds from the 1st of April for the new financial year is a moot point. But the point we've got to bear in mind is we've got to get away from this annualising of planning, because it doesn't work. It doesn't work for anybody. It certainly doesn't work for a system like ours with the pressures we're facing. We've got to be thinking about the longer term. The bang for bucks in terms of investment in primary care, prevention, in terms of the TWIP and SHIP, integrated care initiatives and neighbourhood teams will come in years, but we've got to lay down the foundations for that sooner rather than later. I'm sorry for the hobby horse-ish.
Can I just come back a little bit on one bit of it, not come back on it, but sort of elaborate on it. The other flip side is perhaps where we need to spend the money is in SAF and in acute care and in our orthopaedic, with our elderly, frail population, and in our care. And there isn't perhaps the ability to spend money on new things. And if we reach that point, then we need a level of honesty with the public around where the money can be going. Yeah, I was saying it wasn't a comeback, it was more an elaboration on
I couldn't agree with you more. It's got to be part of the debate that we need to have. And it won't be just, gosh, that's lucky, we've got a plan for next year. It's got to continue. It's got to continue. Claire, did you want to? I'm not quite sure how we got into this bit of territory, but it's an important bit of discussion, so I'm happy for it to flow a little longer.
Probably not a lot to add to what's already been said. I think what we know we can't do is fix the finance problem without reference to quality, patient safety and performance improvement in what we do. And I think that's the difficulty we have. So as you say, Neil, with the scale of our financial deficit, this isn't a one-year plan, and certainly the conversation we were having with the chief execs this morning was about, in order to have a credible plan for next year, we have to set it in the context of that longer term recovery, because at some point we're going to have to invest in certain areas to unlock some of the challenges that we've got, but we don't have money sloshing around for us to be able to do that, and it does take time to unlock it from one area and push it somewhere else in the system. So we're definitely not heading into a planning round of salami slicing and incremental bits of efficiency. We've had a conversation this morning about more fundamental consideration of the cost base itself and the plans that we're developing to look at things like demand management, where we're putting our workforce, are we getting the best outcomes from what we're doing. But yeah, it's no mean feat given the scale of the pressures that we've got.
We need to come back to this whole issue. We can't do it just now, but thanks for raising it. And are you saying more about this later, Claire?
I'll be commenting on the in-year position later,
okay,
which gives a sense
that's
of how
fine.
we're heading into next year.
That's fine. I want to bring in the others who've had their hands sort of raised for a little while. Paul, take your question, comment next.
Thanks, Simon. It's a positive report in places, and can I say the work of SHIP and TWIP is really good, I think, and is the way forward. And answering exactly what you're saying, Julian, the only way we're going to do that is by investing in those areas and making sure that preventative work is affecting the cost of our acute services, and it will do if we get it right. And our partnership with the third sector is integral to that and must be at the forefront of it. We can already see things that are happening in Telford and Wrekin because of that partnership, and it's a really positive partnership. And I think the Independent Living Centre, for example, which means more people are staying at home, is a good example of that. And then can we move on to of course, the hospital transformation programme, and you would expect me to mention that I am yet again disappointed with this. Disappointed mainly because, and I don't see it, and forgive me if it's in there, the recommendations that the IRP have made to us is not as a system. To us as a system is not in the report. But and I also am a little concerned that the enabling works are going ahead before the full business case has been made public. Can I say public feedback is continuing, and I can tell you what the public feedback from Telford and Wrekin is, and you know that, and I don't have to keep responding to it. People are really, really, really concerned about it. And that's not me speaking as a politician. I'm not raising a red flag. I am saying to you, when I knock on doors, the first thing people say to me is, what are we going to do?
Listen, Paul, we know the views of your council. We know the views and the concerns that local people have. We are very confident that we have a plan that will provide the right kind of healthcare in the right places for years to come. But we have an awful lot of further explaining to do. We have an awful lot of further work to do involving people with the development of the detail of the plan. And Louise, that's something I know you and your team are working on. Did you want to?
Can I just say?
Let's hear from Louise, if we may.
Yeah, no, I agree. We're at a particular stage in the programme and absolutely committed to the ongoing engagement with communities. We want to make sure that the changes and the services that we put in place are going to deliver the quality and experience that we all want for everybody that we serve across our entire catchment, Telford, Wrekin, Mid Wales, Shropshire. So we want to work with you and we'll continue to do that. And I think the communication and engagement is absolutely at the heart of this across all the different groups, patients, families and the community. So we want to ramp that up, do that clearly and make sure that everyone understands what's going to happen and ensure that they're able to access the services. Thank you.
And I know there are one or two particular aspects of the IRP recommendations and the ministerial response which you're very keen to see made public and embellished publicly, if you like, and we understand that.
I think it will help, Neil.
That's what
I would say to you.
We agree,
it's
and actually
negative.
we might have differences of opinions of a number of aspects of HTP, but on this particular point I think there's probably a consensus. It's the difference is about how and when we can do it, and we're very keen to do it quickly.
So my commitment there, Chair, with Paul, with David, with Louise and team is to continue to have the really active dialogue and conversation, because I think, Paul, the point you're saying there, which is get this bit right, build on what Louise is talking about in terms of that engagement and conversation, then we've got a collective responsibility to ensure that we build public confidence in the services that we're putting in place going forwards, and as a system that then becomes our collective responsibility to build that public confidence in that. But to do that, we've got to get that dialogue right, Paul, David, that you're flagging, Paul. So I give you my commitment to continue to work absolutely in that space, in that open and transparent way.
Okay. We'll keep the lines open, as they say, Paul. Thank you for your contributions. Roger.
Yeah, thank you. Just going back to 1.3 and Simon's paper about the joint forward plan and the preparations for 24-25 financial year. And I think from where I sit at the moment, I don't have much assurance that within 2 months we will actually have much of a change in terms of our commissioning and contracting objectives. I think it's all very late to try and achieve anything now. So I'd welcome the views as to how we can begin to reshape our commissioning and contracting for 24-25, bearing in mind we're only 2 months away from that start. There's also mention here of national triangulation tool for activity finance, workforce and productivity by provider. I think it'd be very interesting for us as an ICB to see that information as soon as possible, to see what lessons will come from that.
Thank you, Roger.
Sorry, one final point, Chair. Just when we talk about integrated neighbourhood teams and proactive care, etc., all very laudable, worthwhile exercises, I think what we need to do is have some assurance around A, how much this is costing, and B, what actual evidence there is of change in terms of making a difference. How many members of our community are avoiding admission, how are having support. We just want to get some numbers around the quantification of who actually is being affected and having a benefit. Thank you.
Thank you. And of course, it's more than just about the interface with hospital services. There are lots of other services being provided by within the neighbourhood teams. But your point is well made. And of course, we talked about this, Patricia, at the development session. I think we asked you for a work plan and some advice about benefits and so forth. And presumably, there's something on its way to us about all of that.
At the moment, I think we're certainly Lisa Keslake and Claire Parker is sort of driving the programme of work, are working with key partners across primary care and the local authorities on this in terms of what areas are we going to target first so that we get maximum benefits. And you're right, it's not just about how many people are we avoiding going into hospital.
Important though
that is an important factor for sure. It's about the reduction in cost across the system, including mental health and others, by having a lower level and earlier level of intervention. One of the key kind of planks of that neighbourhood work is also risk stratification, because what we're being very effective as a system this year, but it's very costly, is reacting to the people on top of the pyramid coming in and through to the acute services on a fairly regular basis, and there are further people down the pyramid that we need to be capturing, identifying and intervening with further on the line, which is why we're seeing costs, type 2 diabetes flooding into type 2 diabetic clinics being put on, which is ridiculous in the acute trust. That's not where type 2 diabetes should be managed. We've got higher rates of amputees, we've got higher rates of renal dialysis, because we're not actually proactively intervening earlier on in terms of those clusters of patients. So that's going to be the kind of key focus. But not just on health, but across the wider piece as well in terms of social care interventions, so that we're not ending up over-prescribing care, both care and healthcare to patients, that's more costly to them as individuals as well as the system.
Thank you. And the ICP had a really good, interesting presentation from Simon Collins about long-term conditions and variation and impact and changes that could be wrought for the benefit of citizens, which is part and parcel of this. There's a lot happening. We just need to make sure it's drawn together. So, Patricia, if you're not able to say right now when you think we'll get an update on this, are you able to say right now? Can you give us some help with that and just let us know roughly when you imagine that can be made available? I want to come back to the other very fundamental point that Roger raises. 2 months to draw together a plan that will pass muster.
So probably between myself and Claire, but if I make a start. The starting point isn't today in terms of the planning process, so the conversations have been happening already, so it's not then let's start from today and hope that we can solve that in 2 months. Chief Execs received the update today from the planning leads around this. Several key actions from that, which was the individual organisations, ICB included as a statutory organisation's responsibility to go back and look at the asks and the investment that's currently being proposed. Second element then was about making sure that because currently that's unaffordable in terms of 24-25. The second ask then was the areas of collaboration, the areas of joint working. How does that demonstrate better value for money linked with better outcomes with the workforce in the right place and in the right way? And the third element was a conversation that we started and touched on, which was what would be the commissioning opportunities and how do we do that in a way that's joined up to build and deliver integration rather than risk further fragmentation. But the pace around that and the delivery of those elements now was increasingly important, and how do we do that jointly together where that makes sense, but equally recognise that the time for delivery against this needs to be our 3-year medium-term financial plan that sets what will we deliver in 24-25,
what we'll deliver in 25, 26, and then what do we'll deliver in the subsequent year after that, because we're going to have to take some really bold steps in each of those 3 years, and I think that's where chief execs and finance colleagues were at this morning. That won't give Roger all the assurance he's looking for, but that's the conversation that we're directly in. There's work immediately falling out of the chief execs meeting. There's an update in 2 weeks' time. There's an update in 2 weeks after that. Not to just say, oh, we're talking about it, but actually in the nitty-gritty of what decisions are being taken now to change the current spend profile.
So Claire, when do you imagine that we as a board get the opportunity to spend some time to think about this in detail as part of a process of signing it off?
Well, certainly by the end of February we'll have something that has been through sufficient challenge internally within the management structures to be starting to bring headlines to board, and particularly around some of those difficult conversations we're going to have about what priorities we have. Commissioning intentions, there are so many good things that we want to do, but we're going to have to be quite structured about how and when we do them, because we won't be able to do everything. At the moment we're still working on a planning timeline that would have a position secured through March then, but obviously that's very heavily dependent on any final guidance coming out, because we can only estimate some of the performance ambitions and asks of us. And I think, you know, we're going to do some modelling, some scenario analysis as well, in terms of how hard and fast we can go within the limits of the workforce finances that we've got.
And Chair, sorry, I think there's a genuine challenge of us as an integrated care board in this space, and it links to comments voluntary community sector made, local authority colleagues have made. So we've got an NHS statutory responsibility in terms of how we do that planning. We know a number of these schemes and changes have to be done with voluntary community sector, with local authority partners, but we don't have another board that's just an NHS conversation that you would have had previously. So there's a risk the conversation feels really NHS dominated to deliver the statutory responsibilities that we've got in a way that disengages some partners without the intention of it being how do we disengage partners. So I think we've got a bit of work to do through that, because you know the agenda today has got much more on health and equality and how we work in that space. But we know as we get into the crunchy bit of the end of this year, it will shift to our statutory NHS responsibilities that we've got, and that risks disengaging partners when we don't want to disengage partners. But I'm not asking for a solution to that, just a recognition of our challenge.
It's a very reasonable point, and I mean our financial position is just unsustainable. I mean we all agree it's unacceptable, and it has to improve. I think we have to be reasonable in terms of our expectations about that, which will be possible in 1 year next year. But what we need to see, as we've said already, and Claire, you've reiterated this, is a longer term plan about how we're going to make the kind of improvements that are expected of us and which we want to be able to do. And within that, there needs to be reasonable assessments of investments to bring about the changes in terms of transformation of care that we've talked about previously today. So it is tricky, but I think outside of the meeting, Claire, Simon, what we need to do is give a bit of thought to the timelines and when the board can actually start looking at the detail of our emerging plan. So we give people the opportunity to influence it. And presumably, Trevor, from Finance Committee's point of view, you are heavily involved in this already.
Well, in terms of being reported to, I guess my worry in what you've just said, Neil, is that I think you sat in this room this time last year and said exactly the same thing.
I did.
You know, that we can't change it in a year and we need a medium plan in order to go towards. And yet we've got worse rather than better. And so I suppose the very direct question is, do the chief execs and FDs have an agreement on what number we're aiming for?
Claire, is that still work in progress?
It's still work in progress. I think we have a broad working assumption at the moment that we do not want to be in a place where our deficit is worse than it is this year. We have expectation from regional and national colleagues, which we call flat cash, but it basically means that we shouldn't be having a continued expenditure that grows beyond what it's been in Q4, other than for inflation, which is recognised in our allocation. We've got a lot of work to do to define what that looks like and how far we can get towards that and beyond, which is what we'll be asked to do, I'm sure.
Dave?
Given that I've seen what's going on elsewhere, I must admit I'm surprised a little bit that we're now in January and we're not seeing what a first cut pass as a board, a first cut pass of the outturn for next year looks like, because we know what the underlying run rates are, we know what the major assumptions are, we can easily map out what the starting position, and I think we talk about that being something which is tremendously exciting for NHS people and perhaps less so for other people around the room, but I think without that visibility it's difficult to actually engage people in terms of thinking about other things that we can would want to do and how we actually change things, and I think everybody's got a real important role to play in how we change things, but that has to be done, I think, in the light of the realities of where we are, and we're not seeing the realities, and I think this is the time when those realities need to be exposed, and I'm personally disappointed that we're now here at the end of January and we've not got that at this board, because it's being done elsewhere at this time.
Simon, Claire, response?
We do have that, and that is through Finance Committee and through Chief Execs and Finance Directors. So Dave, happy to brief NEDs and take NEDs through that. Providers are clear in terms of currently where they're at in their positions. What you're not seeing is that there's so many moving parts of that, it's not being brought through the public papers in terms of the board, whilst that work is taking place currently with providers to do that sense check and that triangulation. But happy to use Finance Committee in terms of going through that in detail.
Look, I'm not sure I expected us to get into this degree of detail today, but I'm glad we have, actually. I think it's been an extremely helpful discussion. What we need to do outside of the meeting, Simon, Claire and Chief Executives, is just draw together, I'm sure you've got this already available in some way, shape or form, some kind of a process where board members can see quite clearly when they can be engaged again and when they can expect the degree of detail that people are asking for, and how and when they can get the opportunity to influence the outcome. I think that's basically what I hear people are asking for. I think Dave's challenge about why haven't we got a number yet, I bet you there are lots of systems up and down the country who are no better, no worse than we are. Actually, our position is exacerbated because of the extreme financial position within which we find ourselves. But it is important, you're absolutely right, that it's shared with board members in total. And we need to play into that, the local authority financial view of the world, forecast your own position, looking at Andy and David. So let's have some further advice about process, timelines, and opportunities for board members to really contribute further to this important discussion.
I'm really glad I included planning in the Chief Exec's updates, Chair.
So am I. Exactly. Good discussion. Thank you very much indeed, everybody. We're asked to note the contents of Simon's report. I guess we're probably able to do that with knobs on, really. That's great. Thank you very much indeed. Now, as often is the case, hopelessly behind time because Simon decided to put planning for 24-25 into his report. Nick, Specialist Commissioning Briefing Report. Can we do this briefly before we break?
I think we can.
Over to you.
So, first, thank you, Chair.
We've had discussions about this previously.
It's really an update and sort of where we are. So take the papers read and I'll just highlight the salient points. So as part of the legislation which brought ICBs into being, a number of services which were commissioned regionally and nationally are being delegated down to them. Some of these have already been delegated down, such as pharmacy, ophthalmology and dental. Specialised commission service going to start being delegated down from the next financial year. And I'll just explain what we mean by specialised commissioning. often call it a spec-com. There's a lot of work which goes on across the system, which is complex, and clinical teams do work which is special, but it's a clear definition of certain service lines which are described as prescribed specialist services. So there's 178 in total. It needs a very clear service spec, which what the service involves and who can do it and who can't do it, and the funding streams. So as part of this piece of work, the services are going to be delegated down to us, but not to individual ICBs, down to groups of ICBs working together. And for the West Midlands, it's going to be effectively a committee in common of the 6 ICBs in the West Midlands holding it jointly. The reasons for specialist commission services set up originally about 20 years ago was to help manage the risk, because there's a lot of risk in the complexity and nature of the services, and also the financial risk. So there are services which are coming our way. Approximately, the numbers are in the paper, so the work we're talking about is work carried out predominantly by SAF and Raja. So the SAF services mainly cancer and renal work, and Raja is expected mainly specialist orthopaedics, spinal and some bone cancer work. So the services coming down to us, it's about £64 million of activity we commission internally. Some of the work is carried out, particularly Raja, which is your national work, and there's some work cross-border. Over half the specialist work, which is paid for by the ICB, is actually carried out in neighbouring tertiary centres, which is effectively your H&M in Stoke, in Wolverhampton and in Birmingham. So there's lots of flow across borders. Initially, about a third of the work commissioned nationally is going to be delegated down, and that's what we're talking about. There's a lot of work going on underway, which is highlighted in the paper around quality governance, financial governance, and just making sure that there's fairness of access and ensuring that quality is available, but having the opportunity to develop services locally where possible, and that's a balance we've got to remember. So the time frame going forward is tight, like a lot of the time frames NHS give us. So the final draft agreement is, in the paper, says it's due to be out today on the 31st. That's been pushed back to the 9th of February. And that will come down the final draft version of what the documentation will look like. It will be discussed by the Committee in Common of the 6 ITB CEOs, and it will come through to board for final approval. Again, a bit tight deadline of our public board in March, but we hope to get out all the information to all the key stakeholders in advance of that. So that's where, well, we're very happy to take questions, or some of it is quite complex and nuanced, so very happy to take sort of email conversations with people around the table as well.
Thank you. A number of years ago, in a different life, I used to chair the National Specialist Commissioning Committee, and it was very clear that the commissioning for these services needed to be centralised, because they were often rare, they were high cost, low volume, and offered risk to local commissioners. Therefore, they were centralised. There was a centralised view about developing strategies for some of these services as well, and it was a system that seemed to work pretty well. And I say that not because I chaired it for 2 or 3 years. It seemed to work pretty well. So when I read these things, Nick, I think to myself, why are we doing this? What's the purpose? What's the benefit, other than NHSE centrally getting rid of some of its responsibilities and passing it on to local services? So,
should I?
So help me understand this, and I might get more interested.
Do you mind if I answer that first and go to Stacey? Yeah.
No.
I thought you were a bit keen there, Stacey.
Yeah. So I think the paraphrasing your question is, what's the opportunity for the residents of Shropshire, Telford and Wrekin, really? How can we, we're here to improve the health outcomes.
Yeah.
Well done. The politicians were further down.
Well done, Doctor.
And also, as someone who's also worked in SpecCom in a previous job, and I'm still a practicing cancer surgeon who does specially commissioned work, and I used to do quite, another term used to be called highly specialist work. The opportunity to improve the health outcomes is around access and quality. It's not about repatriation, reversing what happened. Yeah, there will be some services perhaps we could grow, but similarly, you don't want to, as a small system, take on services which are fragile. And I'm sure Louise can give you some examples of some for more specialised services which are fragile, and she worries about workforce and quality and some financial issues around it. It's ensuring that we have a voice at the table. So when we have those West Midlands-wide conversations about are patients getting the right access to the services outside the borders. You know, that's an important question, and lots of evidence around further away you live from specialist services, the least access you're going to have to it. So it's a conversation saying people waiting for heart surgery, you live in Shropshire waiting longer than people in Birmingham next to the hospital, what happens. And also the quality conversations and saying, you know, are the standards, the services we're commissioning of high enough level? We're fortunate in a way that we have effectively 3 tertiary providers on our borders we can have those conversations with. But there are some really good services within Shropshire and Telford and Wrekin, which not only, you know, should be proud of, but it can actually grow. I mean, one of the best services, and there's some fantastic services, is the spinal rehab unit in Marjorie, which is a national exemplar, you know. And we've recently put a successful bid to expand and grow the service, haven't we? That takes patients from across not only nationally, but I'd say 4 home countries as well.
So like a good politician, you're doing your very best to represent the corner of opportunity. Am I persuaded? I'm not entirely sure yet, but thank you anyway. Let's bring in Stacey.
I agree, Neil. And I think we're fortunate being a member of the Federation of Specialist Trusts. We've had a lot of conversations with the national team around specialist commissioning and trying to understand. I get some of what you've said and I agree for local people, but when your services span wider, there's concerns around funding flows, I think, which again wouldn't be surprised. I suppose just the plea is the stakeholder engagement as this progresses. I understand the governance elements, but I think we have really good relationships with our SpecCom colleagues, with our networks, spinal networks, etc. It'd be a shame for that to unravel.
Yeah, just one final comment about financial flows, which I might ask for some clarity about, but there's a line in the paper that since we're in Norfolk and we've got such a challenged financial situation, there's effectively a lock, a type of lock there. Any deterioration in the situation with SpecCom, it would actually be held by them nationally rather than us locally, but similarly any excess surplus will actually be held nationally, so we're sort of locked into that position to give us a certain degree of financial stability. Have I explained it appropriately, Claire?
So that makes me even less enthusiastic about it, it seems to me. But anyway, what do I know? So it sounds like this this train is leaving the station, and it sounds like there's a national policy direction that we need to heed very carefully. What we've got to do is make sure that we are absolutely clear about the opportunities and we're very clear about how we're going to mitigate the risks. And I think the paper gives us some reassurances about that, but there is more to come. But Simon, there must be a lot of disquiet about this around and about.
So in terms of the West Midlands, with the other ICB, the same conversations are taking place in terms of the right time to take on the delegation, to add value against the backdrop of everything else that we're being asked to do and work in that space. And it doesn't feel the time to destabilise some of the relationships and ways of working in this space at this point. I think as a board we'll have the opportunity to have that conversation and take a decision around where our board wants to get to, but I think it's worth and I will commit to do that work with my chief exec colleagues to understand where other boards are in this space with provider input as well. We have a structure where we get provider input into those discussions and conversations, and I'll pick up as well to check that provider lead is doing the reach out to make sure that what we're hearing as ICB chief execs is coming from our providers collectively, not just a single view of the world. But I think in March we will have a robust conversation around the added value in this space and the risks that go with it.
Tina, thanks, Simon.
Yeah, not for
And
an
Roger
answer
then.
now, but I would be interested in the future to understand more about the quality aspects and how quality is going to be monitored and quality issues escalated if there's significant issues with the provider. Because I don't know where that responsibility
You see, the
is
great
gonna
thing about the
sit.
national specialist commissioning arrangements was that
Yeah.
gathering data for rare conditions, relatively rare conditions, was relatively straightforward, and you could monitor quality much more readily than I fear it might be possible to do once it's delegated. But I think Roger wanted to come in, and then Dave, and I'm conscious that people are waiting for their
do this quickly.
break. What, this item?
Yeah.
Well, I'm sorry, you've got me wound up about it.
Glad I'm not alone.
Roger.
Yeah, just a quick question. how reliable is the £148 million figure? Can we trust it?
So
Claire.
say that again. What was the first part?
How,
I heard
how,
can we
reli- how
trust it?
reliable is the 140 million figure?
My finance team are doing their due diligence at the moment, and I've got a meeting with the director at NHS England regional team on Friday just to kick the tyres on it a little bit more.
Okay, thanks.
Thank you. Somebody
Dave.
else?
Dave, I think.
Dave. Thanks, Dave.
I'm not sure that it's quite the same here, but I know, I mean, I'm on the board of a large tertiary centre. I know our clinicians there are very worried about this because they believe that it creates incentives for other systems to create capability which won't be delivered on a quality and scale basis that can be delivered in a large tertiary centre. We already know that plans, for example, I mean, this is Southampton, we know that the plans are afoot in Bournemouth to look at capturing some of this commissioning money and developing services they don't currently do, and our concern is a deterioration of quality.
Thank you. So there is a sea of concern around this table, which I know, Simon, you represent in your discussion with your colleagues. It looks as if this is coming. So as we grumble about it and make our points well known to regional and national colleagues, we better prepare for it, which is really what I think this paper is saying. And thank you for that, Nick, and thank you. Simon's looking at his watch. He wants his cup of tea. Let's take a break. It says 10 minutes. I'm going to suggest 5 minutes, and then we'll restart. Okay? Thank you very much.
actually
Let's start again, please.
but this, you know,
but can't be right.
Well,
it doesn't reflect. It will be at an end point.
Will be, but not. And also.
Could you take your seats, please? The next item. The next item on the agenda is the provider collaborative, including MSK update. Fresh from Mount Kilimanjaro, we have Nigel Lee, who is one of the co-presenters of this paper. It says with Louise. Is it Louise or Patricia who's co-presenting this, or is it just Nigel? That's what I thought, yeah. So, are you kicking off, Nigel?
If that's okay,
yeah?
with colleagues. So, thank you. I think, just to introduce briefly, I think we heard with Simon's introduction about the work happening in our two places. And I think it's important to just recognise that provider collaboration is another key part of how we continue to develop our system operating model. So this paper just gives a brief update on the development in the last few months, the work that we've done in terms of establishing the committees in the common, and obviously the shared purpose and the focus on those four initial priority work stream, as well as obviously the next steps. And as you say, Chair, illustrating with MSK being one of those, obviously led through the Chief Exec from Stacey, just making sure that we've got MSK properly registered as a key work stream within that. So happy to take any questions. Harry is our lead chair for the committees in common. Patricia is our lead Chief Exec for the committees in common at this point.
Thank you very much indeed. Comments? Any comments from chairs? Yeah.
Putting aside, if you like, the sort of the delivery of change, etc. What I think has happened is that you've now got a very robust team of providers committed to work together. And I think Simon described it at one of the meetings I went to, is that there are now green shoots of collaboration. So we've just got to make sure we look after those green shoots and deliver them. But I think we've got something actually that is going to be capable of delivering change, which I think is what we do want. And,
okay, Dave?
Yeah, no, it's interesting. The only thing I didn't get from the paper as such was how it aligns with potentially any other broader strategy at that system level, and if you're looking at change, how this aligns to the ability, the enabler, the facilitator of actually making things happen, i.e. through funding. So how does this then play back into funding? If you wanted to fund particular change programs, how does that work?
I think it's a great point, and one of the issues, this is an emerging group, and I think one of the issues that we are conscious of is that actually it needs to be much bigger than 4 providers. Yeah. In particular, I would say Commissioner needs to have engagement, and then of course local authorities, voluntary sector, etc., etc. But it's the start, and I think we do recognise the point you make. I haven't got the solution for it just yet, and what we didn't want to do was create something that perhaps would be too big to manage and not deal with the here and now. So,
Harry, I mean, I think it has to be the right way to go, because I mean, change has to come from, in this area, has to come from the bottom up. Yeah. You know, I mean, it has to be something that you as the providers believe in and are going to deliver. Yeah. I think it's a question. I think it's a challenge back to the system as how we support you in being able to drive the programs you want to deliver.
I think that will happen now.
Yeah.
But in a collaborative way.
Yeah.
Any other comments? Nigel, I'm just interested in getting comments from chairs and chief execs within the collaborative first, if I may. Katrina?
Just reflecting on Dave's question, and it's certainly something
I know I've spoken to you, Neil, about and some others, and that is, of course, as the system is restructuring, the way that commissioning is going to be done will also change.
Exactly.
And so there'll be elements of tactical commissioning that could, as confidence grows, come down into the provider collaborative. So, you know, giving us the headlines as to what is to be achieved, giving us the money to do it, and then depending on the collaborative to actually define the innovation, the pathways, etc., by which those deliverables can be achieved within the envelope that's offered, thus facilitating strategic commissioning at the ICB level, leaving the detail of delivery down to the collaborative level. So I think that's part of how I think I can see us shifting. But let's be clear, the ask from system and from Midlands, NHS England Midlands in the first instance, was to put the collaborative in place to deliver on the critical here and nows, and shifting rapidly into that the situation I've just described as quickly as possible. But the big ask was, can you sort out the ambulances? Can you sort out this? Can you sort out that? But we can't stay there. We've got to shift rapidly as we transition.
Okay, thank you. Other comments? Maybe back to you, Nigel. Oh, sorry, Tina.
No, I was just going to say, I think the trick here is getting the balance between good governance, but not overly burdening ourselves with bureaucracy and being able to deliver on some of these absolutely key things. And it's getting that balance right between governance and delivery.
Thank you. That's a really important point, and I wanted to come to that, and maybe we'll just pick that up now. Meredith, did you want to comment on that point about the balance between governance and, if you like, delivery and implementation?
No,
or was it another
thank you.
point? Do you mind if I just, whilst we're on that topic, Roger, in terms of this balance between governance and delivery, have you any observations from the paper, arising from the paper?
Yes, I mean, my thoughts about the provider collaborative, having been through one in the West Midlands, in Wolverhampton a few years ago, is that you do need pace. And at the moment it's quite difficult to see where the key milestones and timetable is in this process. Because these things are difficult. And without that pace and that energy to deliver it, it will just become a talking shop, for want of a better word. So it's really what the provider collaborative is looking for in terms of tangible deliverables and when they will be achieved, to give us the assurance that the benefits of the collaborative will be delivered. So that's my initial comment.
Thank you. It's a really helpful point, and I suppose that. Sorry, Nigel. We'll get to you.
No, that's fine.
Question I have is sign-off. The governance arrangements and discussions are well underway. Well done. That looks promising. Given our position in terms of NOF, what are the sign-off arrangements involving NHSE and the collaborative? What's the part that you envisage the ICB will play in that? What's the sign-off in terms of Roger's point about outcomes? Those are things which don't come across clearly in the paper, and I know, talking to you, Harry, there are things it's accepted need further work. But what's the process to get to the? What we're all keen to do is, as Roger said, make sure that this works, and doesn't simply become a talking shop, but it's through pace it delivers real improvements. Help us with that.
Yeah. So I think I think what we're focused on is the pace of change, and we do recognise we've got to put in place some governance. Don't think it needs to be overwhelming, but some governance. I think one of the things that we've seen so far, for understandable reasons, is an extraordinary level of interest in what we're doing from the region. I think Patricia's written 2 or 3 papers. What Patricia and I agreed this week or last week is that we're going to meet with NHSE to try and get to a degree, a level of confidence where, if you like, they'll leave us alone and get their assurance through the ICB process so we can get on with it. Because frankly, writing a report every month on what happened at a meeting isn't good use of anyone's time, and then getting a letter back, you know, it's just not
Did
good.
you have to produce 2 within 3 weeks over Christmas or something?
Yeah.
Crazy. Yeah.
So we're going to have that meeting to say, if you like, leave us alone. I think the sign-off, I guess there's a question of what they want. I mean, our view is it's a matter for us, actually. It's our collaborative, it's a matter for us. If provided they've got assurance that we are focused on the right things, delivering against them with the milestones at pace, we think that should be enough. But we're going to have that meeting with them, and obviously we'll engage with yourself, Simon, before we have that meeting. But we need space to operate as well, I guess.
Yeah, I think, yeah, couldn't disagree with that. Disagree with that point. So, thank you for the progress report. Unless there are other comments, questions. Oh, Julie and Louise and Meredith. I think probably Meredith, you were next, and I'm ignoring you again. I apologise. You go now, Meredith.
Thank you very much. Just to say, I think this is a fundamentally important piece of work, and completely support it. And Katrina's point about the tactical commissioning is so critical, because then that allows the ICB to do its specific function properly, because it's not meddling in something that's being done elsewhere, and I think that's great. I just had one slight anxiety. I know this sounds like deja vu. There's a line in the benefits, Nigel, you can probably set it out. It says to embed clinical and community voices in our work, and I just wanted to make sure I understood what embedding community voices in your work meant and what that might look like.
Well, I think through all of the individual trusts we've got work, and please bear in mind this is Robert Jones, Shropshire Community, SAF, as well as MPUFT. So looking at both the physical and mental health side. So with all of us, the trusts have got work about continuing community engagement. I saw something from SAF over the last few days or so, which is looking at, again, there's an open survey to continue that interaction. So I think it's through those, and whilst it won't be a specific priority work stream because they're set out, it will continue to both inform and steer the way in which we do our work.
Just to add to that, I think, Meredith, is also the opportunity, because I don't think the general public are really concerned about whether we've got 4 committees of our board that's chaired by. I think what they're interested in is how is this going to be different in terms of the delivery of care. And I think what's more important is having that community voice in how we deliver on these priorities of care. So urgent and emergency care, the areas that we're focusing on, the children and young people agenda, and so on, and actually listening to that voice, so that as we deliver care, we're delivering care with rather than just to people. I think that's going to be important. So how we bring our engagement and communications functions together to do that as joint providers, so actually listening to the whole, rather than me going and talking about district nursing services or aspects of community care, because they're fundamentally joined up to the other bits. So I think that's where we want to get to in terms of that comms and engagement. And again, I think there's something about us as a provider, collaborative, listening and including people like yourself, Meredith, and the wider voluntary sector into how we do that. So it's not just a traditional health approach to here's a set of services, do you agree?
Thank you.
Thank you. Yeah, that's great. Just when I see words like embed or indeed unleashing, they sound a bit cliched, and I'd like to see some kind of tangibles behind it all to help me understand at least. Anyway, but thank you. That's great.
Okay, I'm going to take the other couple of contributions, then I'm going to ask Nigel, who's had his hand raised for a long time, to summarise for us what next. But first of all, was it Louise? Were you next, or Julie?
Louise. Yeah.
Louise then.
Thank you. It was to an earlier point, actually, which is recognising overall the strategy and plan of the system, and then the contribution that this group of providers can make, and ensuring transparency with the system work. So, for example, in chairing the Urgent Emergency Care Board and working with Gareth on that, that we're clear about the aspects which we are dealing with through the provider collaborative, which are contributing to that overall plan. And we would expect to be transparent about those objectives and those measures and have that cross-referencing. So it was just to identify that we do recognise those interdependencies, and increasingly those will then be set out in those other forums, so that will hopefully work with other providers who can also influence through the different routes and ensure we're doing the right, focusing on the right things.
That's very good points, Louise. Just a thought occurred to me. Will you be meeting in public?
No, it's not a board meeting.
Pardon?
It's not a board meeting.
But you don't have to be a board meeting to meet in public, do you? So, just occurred to me, it might be. Anyway, it's a matter for you to think about. Julian.
Thank you. I've got just a couple of points. I think in terms of the paper's title, which is about an update on the advancing the provider collaborative, I think the paper doesn't, for me, deliver on that. It's, I think one of the issues, I think, and Roger has raised it, I think part of it I would have expected to see a timeline with some milestones, and to do that we probably need for the providers to have an agreed end point. I don't quite know what we're aiming for. What does the end point of a provider collaborative look like in Shropshire, Telford and Wrekin? And therefore then we need to develop the timelines and the milestones towards achieving that. The next bit I think is a little bit, I might be letting out one of the secrets of general practice, but quite often when the ICB ask us to do things, general practice, we look at what we're already doing and say, what can we put down in that list that we're already doing that meets what we're being asked to do? And I think the UEC work, that's already been in train. That's not new. It's what's been started, the virtual wards and the subacute beds and the IDTs. The MSK work is sort of being done. So I suppose I'm asking, why this paper to me doesn't tell me why that's different. What's different about the processes we've now got in place that were different to when the ICB were leading on those pieces of work and now the provider collaborative is. And I think the third point for me is about, I think someone else said, I think Katrina said about making everything a bit more efficient. So in terms of commissioning outcomes, one of our outcomes is we want to see that our target in saving money or be able to have money freed up to be able to redirect it is achieved. Yet in the finance bit of the MSK bit, it doesn't appear to me that, it doesn't really demonstrate that by having the provider collaborative we're achieving those aims any better than we were doing when we were doing it through the ICB leading it. For 22-23 it was half the savings, and I'm not even clear for 23-24 how much of the 1.3 million efficiency target we've achieved or expect to achieve by the end of 2 months' time. So I think for me, I would prefer to have seen a paper which splits down what the final state is, what the milestones are, what the timeline is, but also dividing up the sections into what the structure is, what the governance is, and then really another bit. I mean, the MSK bit is really about what's the output. That paper at the end that's attached about the updated MSK is an output of what the provider collaborative will deliver, as would be the sort of the UEC element of it. And I think they're different bits. So I'm not sure the paper title fits in with what we're being presented with.
Thank you. Good points. Roger, did you want to build on that?
Yeah, I did, thanks. I found the MSK paper quite frustrating because there's some really good stuff in here about reduced years living with disability, optimising expenditure on MSK services, managing more patients through conservative care, etc. All very good stuff. But when you get to the recommendations on next steps are really quite procedural stuff still. And it's trying to get into the next steps. What are we going to do about those key gains for the patients and the population? Because there's no evidence I can see of how we're going to deliver those key changes to the services. It's very much, let's explore and discuss and such like. What we need is an action plan as to how we're going to achieve that. Thank you.
If I can just come in on that point, Roger, there is that plan. I think then recommendations were additional to the current transformation plan that we've got that we agreed at the last committee in common. I'm more than happy to bring the in-depth project plan. The finances are still being worked through for next year off the back of the success of the MSST and getting a baseline really to be able to look to see how that's done and what potential savings there will be through that next year.
I don't want to lose Julian's really important points. I'm going to ask Nigel to comment on those in a moment or two, if I may. On MSK, I shared some disappointment as well. It's great progress on a number of fronts, but let's not kid ourselves. The elephant in the room, or one of the big elephants in the room, is how are we going to provide elective orthopaedics? And as far as I could see, the paper's silent on that. With the paper we've got today, I think is silent on that. I may be wrong, and yet we know from one of the appendices, I think it was Simon's report, GERFT is eulogising the notion of centralising elective orthopaedics and creating a centre of excellence. It talks about a centre in, is it London or the southeast somewhere?
Swelliok.
Sorry?
Swelliok, southwest London orthopaedics.
Is it? Right. So I thought to myself, hang on a minute, we're looking for some steering on that particular point. Where is it? So I'm not looking for an answer on that particularly bit. I'm a bit with Roger about sort of unfinished business on that. And I pick out MSK because we had a big discussion about it in this very room, as I remember, in October. And I'm not sure I feel that we've made a great deal of progress, but perhaps I'm not privy to all of the background information on that particular point. There's progress on lots of other things within MSK, I acknowledge that entirely. Louise, yeah?
I was just going to make a general point, and I know colleagues will disagree if they do in the collaborative, but I think the aim is just to give a sense of where we're at now. So it's been a relatively short time frame. We've all committed to this. We've got some governance...
On the MSK, I'm sorry to interrupt, but we set down some markers for that in October.
Sorry, Neil. I meant because it's
in
about...
overall terms.
No, I appreciate that. Yeah. I think in the paper in advancing the provider collaborative, it was more about the collaborative itself, within which there's work streams. I don't think we've sought to present the plans and ambitions of each work stream in detail in this paper. So I just want to clarify that. So I think really it's more a sense of how the collaborative itself is maturing, what stage we're at. We've definitely moved forward with governance. We've got high levels of commitment. We're working through the crunchy bit on the work plans, acknowledging the points you've got and where we want to go next, so that we can then be confident going forward that that is all in place. And I think there have been some initial actions that have been taken, which we've demonstrated through winter, which have been significant compared to previous years, and more to go. So I think it would be for us to then, on specific issues, be clear about what we then share and present. But we haven't sought to do it.
I can see what's happened here. We asked for an update on the collaborative, which we've got. Great. We also said in October we wanted some decisions and solutions about MSK, including the locus of elective orthopaedics at some point in future. And somebody's attached an appendix to a paper which is an update, and it doesn't quite fulfil what I thought we were going to get on MSK. And I think that's partly Roger's point as well. So how are we going to deal with the MSK issue, which I think is a really important test, not just for the collaborative, but for this board as well. Harry, help us.
So there's two or three things here I want to get to the point in a second. The first thing is, up until now, the MSK has almost been a Robert Jones project, you know, and Mike is the SRO and he's letting it. And that's because we didn't have a collaborative. Okay, we now have a collaborative. And Mike made a very important point that it should be the collaborative that owns it, not Robert Jones. So it's a collaborative decision. I think that was agreed at the last meeting. We've then got the experience of what is happening over the winter, which we need to learn from and look at. We've also got the GERFT recommendations. So there was a recommendation at the collaborative that we take a look at the options to see what the art of the possible is. And we clearly can use the winter experience, the GERFT experience. Up until this point, about future models, we haven't really talked to clinicians. So I made the point that we need to get a clinician's view. And of course, we've got a great way of doing that because we've got clinicians working collaboratively at the moment. So I don't think there's not work going on, there is. But we want to do this properly so that it's clinically owned, clinically driven, and owned by the collaborative. And that work is in train.
Well, okay. I think this is the first real acid test for the collaborative.
Yeah,
actually,
I agree.
To resolve this and quickly, given, I mean, the issues have been in gestation about the future of elective orthopaedics for 2 or 3 years at least. And I thought we'd reached a view in this very room in October about the direction of travel based on, we were told, a clinical consensus. I suspect it's more a majority view rather than a consensus, but nonetheless strong support from clinicians who presented in this room.
But I don't think I think at that point we were talking about the MSK pathways across the system. We're talking about reconfiguring the service now, which I don't believe we've engaged effectively on just yet.
Maybe not. Okay, but let's get a fix. Picking up Louise's point, this paper was never intended to deal with the MSK issue in detail. We have an interest in that following the discussions we had last autumn. Let's get advice about that and how long we think it will take before there's a clear recommendation. And if it involves a reconfiguration, obviously it's a commissioning issue which we need to
that was the point I was going to make. And
Yeah.
finally, there is a commissioning element to this, which sort of plays back to the point I made earlier.
We're going to come on to governance and how that works later. I wonder if there's a reframe in some of this, actually, if we think about the planning piece, because I think agree with what Louise talked about, agree in terms of Harry's presentation and the challenge that's come in. I wonder if actually we could say the priority areas that people are saying we're working at pace and there's more detail that sits behind, actually, if we can start to articulate what the workforce change is going to look like, what the activity profile is going to look like, and then what the efficiency and finance savings is going to look like that takes in place, GIRFT, all the work that's in place, and that plays through into the 24-25 planning process, then actually at a board level, our responsibility is overall system, not to do all of the detail that sits underneath that, because we want to empower providers to work in that space. So I wonder if there's a reframing of the ask around UEC and around MSK to say that's got to triangulate now workforce activity and the financial savings that will flow out of that into 24-25. I think there's a separate strand then which is around system architecture and governance, which is about what does the future provider collaboration look like, what's the end, Julian's comment of what's the end point, and I think that's still the development conversation of where we're trying to get to. There's a risk we conflate and we try and pull all of that together, actually, whereas I think if we take the priority areas, of which we know there's been really good work already to get to this point, but the papers in the board today don't quite hit the mark in terms of answering slightly different questions than the first ask was, and we play that into the planning for 24-25 and we lock that in, because then that gets us into the other bit, which is so what collectively are we going to agree is the commissioning intention, the commissioning ask of what that looks like going into 25-26 and 26-27. Now, we could write that in sweet isolation, couldn't we? But that doesn't mean that'll get delivered. Actually agreeing to do that collectively and jointly as a reframe, building on the planning conversation, locks that in.
I think, for me, the discussion about MSK needs to be taken outside of this meeting. We need to find a way of resolving that quickly, because it's been an issue that's been on the table for 2-3 years. Great progress, but the elephant in the room about elective orthopaedics and how that can be provided is still outstanding. And we said ages ago we needed to have a resolution, and we've had GIRFT advice about what that solution might look like. So please help us with that. Please help us with that. Nigel, what next?
Well, I think obviously colleagues have said that. I think, if I may, there were the 3 points I was just going to make, but I'll precede that by, I think, Louise mentioned, Harry mentioned, this was the first time we've had an opportunity to just properly give an update on the provider collaborative to this board, and it was important to just make sure that we were clear about the baseline of that. So I was just saying, Neil, this is the first time we've had an opportunity to present an update on this, so I think it's really important. The fact that we've had some hearty discussion on a whole range of different elements, I think is really important and useful for that, and we can take that away. I think there's 3 elements I think I would take, and very kindly, chairs and chief execs of the trust, I play a part and support that. I think the first one is we absolutely want to continue to develop the collaborative. I think Harry just pointed to that. There's been some great work, and we know that there's areas of development that we want to do, and that is about understanding what the work streams are, how best we're going to do those, and that includes making sure that we develop together, and I think that's the important bit that we want to push on. And the second bit, and Simon alluded to it, is we want to make sure that this then, the collaborative, is an important function and component within the system. you know, the collaborative is not the only thing, the only key component. You know, we've talked earlier about the two places. We've talked about other different mechanisms. So this is really important, and again, we'll talk about it later on in the Good Governance Institute. We understand how the different components of the system operated model, underpinned by both the strategic and tactical commissioning, allow us then to do things differently in a way that we want to move forward. And so that is a joint dialogue then between the providers working with the ICB to make sure that we understand how we're going to do stuff. And I think the final one, and again colleagues have mentioned it, is we have indicated it, and I think MSK is a good example of where we've got clinicians of all varieties, you know, therapies, medical staff, others, talking about different ways of working and how that's happened. And I think the joint work on the pathways linking from primary care, first contact practitioners through therapies, and that involvement has genuinely involved a whole range of different parties, which is important. But I think in terms of signalling a different way that the trusts want to work together, then that is, you know, we know that communication is an area that we want to continue to work on. And so I absolutely understand the points that colleagues have made, but I think those are key areas that, you know, we've absolutely talked about within the committees in common, and I know colleagues are really committed to.
Okay, thank you. And I mean, for the avoidance of any doubt, let's all recognise the good progress that you have made, the fact that the governance arrangements are developing as far as they have done is to your credit. The fact that you've got at least an initial view of your priorities. There's some further work that needs to be done, picking up Julian's point about are we all content that they are the real priorities, NHSE, you and the ICB, and views about outcomes and outputs for those and timelines is something that we need some further advice about. And then there's the MSK issue, which we won't go over again. We've had a good thrash around that.
Just on the priorities, we were actually written to by NHS England, laying out what the priorities were, so that they are the priorities, although we don't disagree, because they are the priorities that are driving quality, cost and efficiency. So we kind of agree with that.
And it was Simon and Rebecca that jointly wrote to us.
Yeah, and I think as an initial statement of priorities, they're extremely helpful.
Yeah.
What we can't agree, though, is that they are the priorities until we've been through our planning process. That might confirm or otherwise the priorities.
Indeed, yes.
And that's my only point. That's my only point. Okay. Thank you, Nigel. Thank you all very much indeed. It's good to see the progress that's being made in this area. Late, I apologise. Liz and Tracy, you want to talk to us about tackling inequalities in access, experience and outcomes. Over to you.
Can everybody hear me? Because I haven't been able to hear much of the board, no?
Can't hear you at the moment.
Okay, is that better? Oh, that's better. Sorry. Okay, so thank you. So, core aim of the ICB is narrowing health inequalities. Firstly, I'd say much of the work in terms of tackling inequalities, promoting healthier lifestyles and well-being is taking place within our health and well-being boards and with wider partners. I think last week we had the ICB, and there was, I think, a reflection in terms of the need for this board to be more cited on that work that is taking place within the health and wellbeing boards. However, this report that's set out here today is the first for the ICB, so that is good news that we've got inequalities on the agenda, but it is about the delivery against key programmes of work that is within the NHS operating guidance, the long-term plan and the Core 20 programme. The Core 20 programme is about addressing inequalities in access to health care for targeted interventions focused on our most deprived areas. We have 60,000 people living in those most deprived areas, 45,000 in Telford and Wrekin and 15,000 in Shropshire. So it's really making sure we are narrowing those inequalities. So we have set up a group, a system group that has both directors of public health and lead execs from each provider. We've met two times and held a workshop. So this report highlights the programme, the progress against those NHS programmes that are being monitored by that board. I think for me, my reflection would be the bigger health inequalities. We have started to develop a data tool, but at the moment I would say we are knee deep in, we can't see the wood for the trees, so we do need to make sure that we use that data tool appropriately and we shed light on whether we are narrowing the inequalities at a population level. And I think there's more work to be done in terms of that, but we have started that piece of work. And I think the second question is, are we integrating our approach? And again, I would say that we would reflect we're in very much in early days in terms of that. This report is highlighting the NHS programmes. We need to now link with the local authority programmes. And therefore we held a workshop before Christmas where we highlighted a few key priorities in terms of trying to do that. So we've talked about a Waiting Well initiative, focused on the MSK, those waiting on the MSK, how can we signpost appropriately to the healthy lifestyle and wider self-care offer that is available in local communities? How can we promote providers in terms of becoming more anchor institutions, in terms of thinking about their role as big employers, big providers of services, big procurers, in terms of helping to support the tackling the wider determinants of ill health? I think we need to do more work in terms of systematically ensuring we signpost to the prevention offer that is within the communities. I was a bit disheartened to see from the big conversation survey that only 19% of those respondents felt they were signposted to self-care and healthy lifestyle. So I think there's more work to be done there. And lastly, also more work to be done in terms of that understanding of our needs and whether we are making a difference to those inequalities within our populations. I'll leave it there, Chair.
Thank you very much indeed, Liz. And Tracy, did you want to add anything?
No, I think Liz covered that well. I'm here to speak to any elements of the NHS programme.
Answer any awkward questions.
Thank you very much indeed. I've said it on more than one occasion, I was heartened by the discussion at last week's ICP. We've had some reflections of that today. Just a sense that using ICP as a bridge between the health and wellbeing boards and the local authorities and this board, it offers significant potential. And we had a good discussion about some of these related issues there. And here we are again with a paper and a very helpful update about the kind of progress we're making. I have a sense that things are starting to move. Liz, am I being too dewy-eyed about this?
Possibly, but I would say at least I think we're more aligned with having those conversations, but it's actually, I think, back to a theme of this board today, outcomes and tangibles. And I think we're not quite there yet.
Okay.
And I think we're probably trying to feed the beast, to monitor the programmes we're supposed to do, but are we making a difference and are we joining up? Hence why I asked those two big questions. And I don't think we're there yet, but at least we're
the conversation.
We're having the conversations. Absolutely. I mean, this time last year, I would reflect we weren't.
Yeah.
So there you go.
Let me invite people to comment. Vanessa, what's your take on this?
Well, as you were talking, I was just thinking about the role of QPC actually, and how we need more going into there around health inequalities and linking it with the other quality priorities in the system. So I think we're at that stage of the year where we'll be looking at our quality priorities, and I think we really need to make sure that we play it in, not that we duplicate, but that we benefit, and that there's an integration of health inequalities within the quality agenda. So that's what I was mulling over as you were speaking.
What about our provider colleagues? What do you make of this agenda? What do you make of the paper? Patricia, any thoughts?
None initially, just urgency.
Will you come into our Shropshire Commons board in April, aren't you? Because we're going to have a focus on this very area. I suppose what I'm interested in is what's our contribution to this
that workshop, which was only a few of us in terms of that, but in terms of thinking about what providers can offer as employers, as buyers of services, as using that lever as much as your healthcare lever, and ensuring equity of access and making sure you're narrowing inequalities in terms of your focused approach with some communities.
Katrina, I've always seen you as a proponent for this agenda, this kind of work. Have you any observations, thoughts about the paper and other things you've heard?
I'm actually just reflecting on the fact that we as a board at SAF we identify that health inequalities is really important, and we know that our staff on a day-to-day basis actually do work very closely with the patients and the service users that come through to talk about opportunities for improving health, what's their hurdles, what's the issues that they face, timeliness of appointments, especially around delays for surgery, etc. But I was just reflecting that we've got a seminar actually coming up on when thinking about the role of the acute provider, other than the conversations that are had. What is our role as an acute provider where we can genuinely make a difference? And I agree with you, the staff well-being, considering the number of staff we've got, and if we think collectively in that, is really important. But there is a lot more we can be thinking about. So I'm just reflecting on that as I'm thinking about the paper. I think I could comfortably say that it would be challenging for us to determine how specific health inequalities are playing out with regards to specific patient flows that are coming through, other than things like maternity, where we've got a really strong focus on things like no smoking at the point of delivery, for example. And that's where it's obvious, because that's where the data are collected. We don't necessarily collect data about the impacts of inequalities on the impacts of outcomes, etc. So we've also talked at board several times about how people from different communities, different postcodes are impacted differently. And rather than us do the analyses and getting into places like that, again, we've been talking about how do we reach into the system, how do we reach into the experts, so we can look at it as a collective rather than us do some number crunching behind the scenes.
Thank you, Patricia.
Yeah, just following on from that point, actually, which I think is really important.
Could you speak up, Patricia?
You know, not just looking at it from an organisational level, and we have got our sort of board seminar looking at our
Your
services.
mic doesn't seem
the
to
point of access, etc., is all very relevant. But I think there's something fundamental, and that is how we're going to commission services so that our services are aligned in the right area, and that might require this board and the components within it, politically and otherwise, to agree that one area might have a different configuration of resources to another in order to start to do that. Because the danger of us just looking at it at an organisational level is we might end up driving up health inequality. So I think absolutely there's something about what are we doing now in terms of access. We're all really aware of some of the health inequalities in our areas. The question now is how do we align services and how do we commission services, which might have to mean some brave decisions so that we start to really turn the dial on closing some of those key gaps.
Thank you very much indeed. I know, Nigel, you want to come in, but I'm going to ask you, wearing your planning cap, to describe how we draw all of this together, including within our planning round, prioritising and so forth. But I think, Paul, you wanted to come in, Trevor, and then Meredith.
Just quickly, on our children's services improvement journey, we talked always about the Telford pound and how we as partnership worked on using that Telford pound to improve the outcomes for children, and I think that's what we're doing now. That's what TWIP is doing, and certainly SHIP is doing, and we should look at the Shropshire and Telford and Wrekin pound and make decisions. We had the conversation earlier. We have to make brave decisions sometimes. It is invest to save, and it is invest to save at the acute end as well. not just at the community end. And it is about how we can work differently with our communities. It's about population health. I think PCNs have a huge role to play in partnership with us in that approach and the way that we offer the services, and hopefully help to solve some of the 8 o'clock rush issues that you get to see a doctor when you could see somebody in a community centre in a different way. That kind of effect will have an effect on those inequalities that are there for us in Telford, and to hear that figure is quite frightening, really. But, I know that there's an age difference within my ward. There's an age difference in terms of death between streets, and for me, in the 21st century, that's appalling.
Thank you. I've lost my bearing. Meredith, I know you wanted to come in.
Yeah, thanks very much. Trevor as well, yeah. So I'll quickly get myself out of the way. Just very quickly, just picking up Vanessa's point, I think Quality and Performance Committee can play a part in and requiring a focused question of all papers, which is, and what's the specific inequality message in this paper, to actually kind of guide us, focus, get our lens in the right place. So I'd stress that's a really important part. Second thing is we've got 2 really well-known experts who are kind of charting what's going on, and they say there's some movement and progress, which is great. But I'd really be interested in Liz and Tracy's view about what would make the biggest difference over the next year, rather than us sitting here coming up with our views. We've got experts in the room.
So hang on to that question for now. I'm going to take the other questions and points that people want to make. Trevor, I've been ignoring you for too long.
It's all right. I've been quiet for a change. For me, this is an area that actually really pushes the ICB, ICS to the full extent of what it should be doing, in that health inequalities is only partially, and probably very partially, going to be solved by changing the provision of health services. This is what the local authorities will be thinking in, day out, whether it be housing, whether it is schooling, whatever else it might be, and even takes us into something that we rarely discuss around this table, but is one of our 4 pillars, which is around the economic effect of what we do. And it really, in fact, so, no answers, so really just a broad statement as to how we use this to really address that broad ICB and why we're here, and what we can do with the group of people around this table that no other table can achieve.
Really powerful point, thank you. So I've got Julian and then Roger.
I think mine's a very quick question. I mean, I agree with everything that's been said. I mean, the health inequalities is, or correcting those health inequalities or providing services to help sort those health inequalities is what we're here for, really. And I think, first of all, we need to recognise the amount of work that's already done in the councils and the public health departments around that, and the fact that we need to be building on that work. I think the highlight report is a really detailed and good piece of work that I think has got a lot of things in it. And I suppose there are some specific questions in there which I don't necessarily need to ask, but my question, I suppose, is whether we're triangulating that highlight report, which I know is written by the ICB leads in those commissioning areas, in terms of our planning for next year. So, for example, on page 221, it talks about in asthma, and it talks about the, we know there's a challenge with asthma. We've had these very 2 tragic deaths over the last couple of years, one very recently in Telford and Wrekin. And it points out there's an 8-month wait to see a respiratory paediatrician in South. It then points out that we haven't got a commissioning decision on the children's nursing team around the asthma reviews for next year. The next page down on page 222 is about diabetes, and I think it highlights there that there's some of the challenges, lack of clinical leadership from SAF, and trying to identify a diabetic lead in SAF. I know these are a bit out of date, but I suppose my question is, are we using these detailed reports to drive that conversation we had earlier about how we pick what we're going to spend our money on next year to try and reduce health inequalities? And are we actually using all the information and the work that's being done in the councils, public health departments, on our own teams to influence what we're actually doing. Because it would be a shame that all this work is done in the background and then it's not really acted on. And I think the other bit is around, you know, I'm here as a clinician, Nick's here as a clinician, but, you know, it needs clinical buy-in at all our plans, whatever they are, whether they're MSK, out of hospital, you know, health prevention. It all needs clinical buy-in, not just at doctor level, but at every single level. And it's how are we stimulating that clinical buy-in to work as a whole system.
Can I, just on the points you made, I really want to hear Nigel's views about how we draw all of this together in a moment or two, Nigel, in terms of a cogent plan, and how do we make sure the great ideas are percolating through this report, lock into that discussion about priorities and what we're going to stop doing and how we're going to fund things. Because I think you, again, put your finger on some really important points, if I may say so. And Roger?
Yeah, I think I've got 3 quick points. First of all, this is very much about what the NHS should be doing. My question is, why don't we do the two together, what's happening within the local authority area as well, so to bring the two together. I think that also then picks up, how does that then feed into our commissioning goals, and that picks up Julian's point about particular at-risk groups. And I think my final point is, again, it's this RAG rating table here. And my worry is that, is there optimism bias here? I've never seen so many greens, and I'm just wondering, are they really green?
Good point, good point.
Answer a few of those questions.
Yeah, do, please.
Right, so I think I agree there is probably optimism bias, but don't forget this is about delivery of programmes. So if you've hit a milestone, you're green. It might not be making the difference. So I think we've got to be able to understand that, and it does depend on how ambitious we are with the plan. I think in terms of priorities, I was asked in terms of priorities, so I'll wear 2 hats then. I'll wear a hat that says, absolutely, you need to have data-led decision-making within this board. Back to the point in terms of being able to see the wood for the trees and being able to target the key outcomes that are going to make a difference to inequalities and populations within Shropshire, Telford and Wrekin. I would also say you need to have brave decision-making. That follows that data-led decision-making. So those are about the enablers. As a Director of Public Health, I would say 3 things to you. I would say best start in life in terms of narrowing health inequalities. Nobody can argue with that, and I think we've got evidence that we are not giving the best start in life to many of our babies and children within, and back to the point is within the gift of this room, and I think that is within the gift of this room. I think CVD and diabetes, we have poor outcomes. CVD is what's driving our life expectancy gap in both Shropshire and in Telford and Wrekin. You have primary prevention and secondary prevention interventions that within the gift of this room. And I think lastly, I would recommend thinking about yourselves as anchor institutions and what you're doing in terms of the wider determinants. I'll leave it there.
Brilliant, thank you. And Nigel, how would you like to?
Yeah, having been invited by Simon to take on this portfolio about 3 or 4 weeks ago, albeit you know I do lead on this you know through Katrina and Louise. I think there's a couple of things, and Liz and Tracy did mention this. I do feel, and so again I might be my own dewy-eyed, but I do feel there's been significant momentum over the past sort of 6 to 12 months on some of this. And I think that's important, not just in terms of the way in which we're talking about some of the programmes of work, but that we're all talking about these programmes of work. And we've just heard from, you know, Katrina, from Patricia and Tina. You know, there is active interest by all the boards for all the right reasons to make sure that we're involved in it, and we'll be talking shortly. You know, I know Kathy's been asking that from a strategy committee perspective. So I think that is really, really important, and it goes to some of the points that Trevor and Roger have made about the role of this board and making sure we're starting to talk about it. This is an important paper to come to the ICB to make sure that we're talking about a key area which we know we want to focus on. The second bit is, I think, from a planning perspective, certainly from the operational plan, and Liz alluded to it, we have some pretty dictated areas of focus there, some of which come with, some of which we crack on and do, some of which come with non-recurrent funding, which not necessarily is easy to confirm whether it's continuing in others. I know asthma is one of those. So there is ongoing dialogue between all of these different teams. I think I was just going to respond ever so slightly. I know Julian was talking about the clinical engagement. Within these programs, let's say maternity, let's say asthma, let's say others, there is a significant amount of on the ground clinical, and I mean by that doctor, therapy, nurse, other different trades involved in this work, and a huge amount of commitment. I think the other bit, if I may, and it does link to the joint forward plan. It's a significant priority within our joint forward plan, and long should it remain so. I think the bit that Liz alluded to is one of the other pieces of work is, yes, we had the joint strategic needs assessment, we had the information, and Paul talked about some of the aspects there. We've got that, but I think what we didn't necessarily have was as agile an intelligence picture to start asking the so whats, and how best we focus our efforts and allow us to have that intelligence-led decision making. The work that with Julie Garside, with others, and it was illustrated here. I know, Simon, you and I had a very brief illustration of that a couple of weeks ago. But my recommendation is, and certainly I'm going to recommend it to Katrina and Louise, is that I think that is something that boards need to be made aware that is there, and this, not necessarily go through it for 4 hours, but just an example of the utility of how that information is able to be used, and then that will help us do that decision making in the way that I think we need to. So that would be my comments.
Thank you very much indeed. I just want to go back to the point about making sure that we've got a process that enables this analysis, this discussion to feed into the planning work that's taking place at the moment, the planning prioritisation, etc. So we don't lose it. It's really, really valuable. Did you want to come in on that point or something else?
Yes, please. Just lean into the mic to see if it's picking up my voice. Can you hear me okay? Because I can't get feedback that I'm on the mic. So in terms of the work that's in Appendix 1A, which is the highlight report, and all of those detailed plans, they are fed in already into our commissioning intentions for 24-25. I'm also a member of the planning group, and I lead on this piece of work. So I'm taking the work that I'm collating as part of those highlight reports into the planning meetings, so that there's actually that handover between the two parts of our work. And I think it's a really important point that health inequalities needs to be, and I spoke about this, when you spoke at the beginning, have we improved? I came 9 months ago and gave a report to this board, which was very, very different to the report that you're seeing today. So yes, we have absolutely moved. We've moved in terms of leadership, and that's the leadership both around this board and in the individual provider boards, and also the leadership of individuals. So to the question, are we being optimistic in terms of green? Well, actually, the individuals who are delivering on the ground these projects are very committed to their work. So those greens are greens, and it's a difference in terms of those individuals who are really committed. We heard the individual patient's story of just how committed that one member of staff was to ensure that she delivered on health inequalities. So we need to make sure that we are linking and not seeing health inequalities as a separate thing that's happening over here and isn't part and parcel of our planning work and our priorities. And the way that we're currently doing that is by ensuring that I'm leading not only on the NHS health inequalities, but also being a member of that planning committee and commissioning intentions. So just to give assurance, we've got a process by which I'm feeding back through the work that I'm collating and leading over into the planning processes.
That's very helpful. Thank you very much indeed. I'm sorry, I'm going to have to move the conversation on, rich though the debate is. We'll be returning to this time and time again. This is what an ICB should be about, frankly, and thank you for reminding us of that. Thank you for drawing issues to our attention as you have done today. Liz, this might be your last ICB board meeting, I guess, potentially. Aren't you retiring at the end of March?
I shouldn't look so happy, should I?
No,
Yes.
no, you
I don't
shouldn't.
know what face to pull.
We will miss your contribution. Let me just say on behalf of the board,
Thank you.
in case we don't get a chance to do so again, thank you for your contribution, not just on this issue, but on so many issues that we've had contact with you about over the years. CCG days, maybe even PCT, I don't know how long you've been around. CCG. So we wish you a thank you and a very long and happy retirement. Thank you very much. So if I ask for a round of applause about my timekeeping in the agenda, I don't suppose I'd get one. I'm going to ask for your forbearance and beg another half an hour of your time, if I can, please, because we really do need to get through some of these other issues. If you need to go, you need to go. I fully understand. But let's see if we can get through the rest of the agenda, or most of it, within the next half hour. Moving on to the integrated performance report. Claire.
Thanks, Neil. And yeah, there's a challenge to try and get through this as quickly as possible. There are some really significant challenges. We've touched on a lot of the things that are in this paper already, and a lot of the key messages that are contained in here will not be new messages for member of this board. So it's no surprise that the two particular pressures that are highlighted are urgent emergency care and finance. I will come back to finance as I walk through the headlines that I wanted to make sure board members were cited on, because there has been a significant change in the position since the last time we met due to the reforecast that we've done, but more about that in a moment. I'm going to rattle through some headlines. It's going to feel very much like I'm reading a list for pace. But actually there's some really important highlights that I wanted to just make from the very comprehensive content in the report. First of all, for primary care, just to note that we have, what an acronym, PCARP measures, Primary Care Access Recovery Plan. These are some really important measures that we will start to be pulling through in more detail for our committees to look at and for board to consider. So it's a watch this space for that, but actually a really important development in terms of the reporting that we're able to bring here. I then wanted to touch on some of our significant areas of focus, particularly around performance, and some of these board members will be very close to, particularly around the reforecast conversations that we've been having. We're seeing significant positive variation across our elective and cancer targets. I'm really pleased to flag that we are now achieving our faster diagnosis standards and our fit testing targets, so testament to the work of the teams there. Equally, our long waits are coming down. We are confident in delivering 78 weeks at the end of March, so there'll be 0 patients waiting more than 78 weeks. Robert Jones, I know, have particular mention here because you've mitigated the risk, Stacey, of the 4 particular cases that you'd got. And we are on track to deliver our reforecast target for greater than 65-week waits as well, which again is great news for those people on those waiting lists. We're slightly behind plan overall on diagnostics, but just worth a mention is radiology, which is delivering more than the target percentage for 6 weeks, well, reducing over 6 weeks waits. Moving to mental health, children and young people mental health as well, we can see improvements across all areas, but I do still need to flag talking therapies, which is quite a challenging area for us at the moment. However, I know that Quality and Performance Committee received a report on that last week and had a look at some of the recovery trajectories that are being put into place. Urgent emergency care, I can't avoid it. We are not seeing significant signs of improvement there, particularly around our over 1 hour ambulance waits, the 4 hour A&E target and 12 hours in department. However, we have seen some improvements in our time to initial assessment, and we are better than the regional average for the first time. So I think that's worth a note there in terms of that improvement.
There was also a deep dive on urgent and emergency care again that went to our Quality and Performance Committee, and we are seeing year-on-year improvements in quite a significant number of our metrics. It's just that we've still got a long way to go. I did want to just mention workforce as well. In positive news, our sickness and turnover rates are the lowest that they've been all year, so we can see some of the actions that the teams are taking actually manifesting now, and we just hope that we're able to hold those and improve further where we can, but that's significant progress for us. And Dave, you've already mentioned earlier the whole-time equivalent numbers being over plan. That's one of the areas that we're looking at as part of our 24-25 planning and seeing if we can better refine really our estimates around those areas. I think there's been a propensity in planning to be quite prudent about how many people we can attract and retain through that process, but we're going to unpack that a little bit through the work that we're doing. I think we've still got some concerns in that area. Pharmacies of note, we seem to be having reducing numbers of pharmacists across the patch. We're seeing increasing vacancies for allied health professionals as well, so there are a few areas that I know our HR and OD colleagues will be particularly focusing on. Finance, to mention, as I say, slight difference in the numbers that are physically reported now. We have had our reforecast position agreed and accepted, so the significant risks that we've been channeling through our paper for some months are now crystallised into the position. So you will see us reporting 132.8 million forecast outturn, and that's inclusive of around £3 million cost of the most recent industrial action. As has already been mentioned, that is disappointing, and certainly I know that's something, a sentiment that's shared by all of us. It means that we do need to regroup on the planning, and I'm not going to open up all that discussion again, but it definitely gives us that impetus to make that improvement. What I can say at this point, after we've looked at our month 8 and month 9 numbers, we're doing a lot of work on run rate. Are we stemming the flow? Are we, is our expenditure coming in line with that reforecast position? We've got a few ups and downs, which is not unexpected, but all of them are explainable, and there are plans in place to take us through to the forecast to the end of the year. So there's nothing that I need to flag either through Finance Committee or to board here at the moment. We're sticking to the plan for that reforecast. I know there are still risks in those numbers for all of us, but we all have that commitment through our individual boards to make sure that we hit that forecast position. Apologies, this is really whistle stop. Finally, just a point of note really, and an ask of the board, Neil. We've had a request from the national team if we would be interested in being put forward as an exemplar for our integrated performance reporting.
Not for the content.
Not for the content, but for the report. And we actually have an offer from the national lead for the Making Data Count programme to come and do a session with the board about how we use data and how we interpret it. I would strongly encourage that we take that up, but obviously
we
I
need
just
all
want
the
to make
friends we
sure
can
we're...
get, so
Yeah.
let's, I'm sure we could all agree.
Here's how you create a big number.
We present it very well.
Yeah, we do.
Yes.
We present it very well.
So fabulous. I will
Thank
take
you
that
for
away and we'll
That-
organise that.
that's really
Happy
good.
to pick
And
up
I'm-
any comments.
I
or
imagine
questions.
people have read the papers in advance of the meeting. Are there any questions, any comments? I mean, we've had a couple of extraordinary part 2 meetings where we've been discussing the financial position, the financial plan for the rest of the year. So I don't propose to go into all of that by any stretch of the imagination, but any comments, any questions? I've got Katrina.
Just a point, just to offer a point of reassurance and clarification. In the quality section of the cover note, it was saying that staff are prevented from doing deep cleans. Just to be sure, we are able to do deep cleans. What we're prevented from doing is doing a total programme of annualised deep cleaning, as most hospitals would do with redecoration, the 5-day decant award, put it somewhere else. But every opportunity we have, every time a patient moves from where they are, then our cleaners go in and they actually clean. So the wording is unfortunate. It's not preventing. We do it. It's just I wanted to reassure the board that the cleaning is being done.
It's the deep clean programme of the whole ward.
It's
that
the
was meant to be.
It's the
and we know
annualised deep cleaning programme that we most definitely should be doing. But without decant capability, we can't take the award to smoke it out.
And that's what I'd assumed when I read it. But then I was making a connection between that and that. Is there something in the paper about some of our infection numbers are higher than they ought to be? Is there a correlation between...
It's in the same paragraph.
Yes,
yeah, right. So is there a direct correlation?
Yeah, so a key action to keep Clostridium difficile under control is to do a deep cleaning programme every year to get around each ward, decant.
Yeah.
In an ideal world, completely have a spare ward, completely decant, clean the ward and move the patients back again. Now, that is an ideal world. Not all trusts can achieve that anyway, because they've always got an empty ward. But even most trusts manage to do it partially. I know the Community Trust and Robert Jones National Centre have achieved that this year on their wards. It's been a real challenge at SAF because of the UEC pressures predominantly. But there was some good news that at Christmas, the November industrial action period, going up to Christmas where there was slightly less pressure, there was some opportunity taken, wasn't there? And bay by bay, some work was done.
We take every opportunity at every point of time to do a deep clean.
Thank you.
That's what I just wanted to reassure.
Thank you. The one question I wanted to ask is, I assume that for the ICB and for the NHS providers, there is a plan that shows how we're going to deliver. Each of us is going to deliver our part of the year-end position, and I presume, Trevor, that will be shared with your committee in terms of assurance, etc. Is that right, Claire?
We're mapping the run rate as I described it through the finance committee. So if any of the individual partners deviates from their reforecast position for the month, we ask for an explanation of why that variation has occurred and what actions are being taken against it. So that will continue over the next few months.
You happy with that, Trevor?
Yeah, I mean, I always worry when I hear the phrase that a number is at risk, because we hear that right from month one, basically, in the annual forecasts. But yeah, I think everything's been looked at. There's a strong sense that we've got to hit that number now.
Well, I mean, the point is, we've pretty much been given credit for the number we asked for, and therefore, not to deliver it would be very, very difficult indeed to be able to defend, and therefore it's incumbent upon the ICB and the providers in particular to be absolutely on top of this, almost every living minute, to make sure we deliver it. And next year and beyond is another matter which we've talked about already. Okay, anything else? Thank you.
Can I just say?
I'm sorry, Julian.
Just on the papers, just make sure that we can double check some of the tables. I think particularly on Appendix B on the quality metrics, there's a bit missing. So it's particularly issue around neonatal deaths and saying SAF have brought in their external agency, but the bit which says when the finalised report's due is being cut off the table, cut off the page. It's just really just to go through.
Well, can we remedy that? I mean, not now, but
no. Just as someone, I think people will be looking at that and will say,
yeah, that's a really good point. That's all of the areas for there to be an omission.
Yeah.
If you can pick that up.
Yeah, we'll take a look at that.
That's really helpful. Thank you. Okay. Chief Medical Officer, Chief Nursing Officer report. We thought it was about time that we had this kind of report on a monthly basis. If Nick and Vanessa will forgive me, I'm going to ask, assuming that people have read it, rather than you introduce it, if people would raise any questions. What I have asked is for Vanessa just to give us a quick update on measles, which would normally feature in this report. But if you want to do that, Vanessa?
Yeah, I can do, and Liz is going to correct me. I feel like I'm stealing Liz's territory. Measles has been all about preparedness until really recently, when we started to see it's moved up the M6, and we've had a first case now in Shropshire, Telford and Wrekin. So all of our preparedness has been very done as a system. It's been a group meeting since the beginning of December, really regularly, looking at how we, what we'll do in sort of how prepared we are from the public health perspective in schools and communications to schools, how we are doing with GPs and vaccination. And most of our GPs have got over 85% vaccination rate, but actually 95% is needed to, and some have got that as well, to get herd immunity. And then we've also looked at, with the Acute Trust, worked very closely with John and Hayley to get a pathway for the post-exposure prophylaxis that's needed for severely immunocompromised people, and we've got that kind of outlined, but until you actually test it out, it's extremely hard. So we did have the opportunity to test it out last week, and there was good lessons learnt, and some of it worked really well, and some of it needs improving, as you'd expect with the first case. We're meeting again tomorrow. We meet every Thursday, and there was a big incident meeting after the first case to try and make sure that we contain measles as much as we possibly can. It is highly infectious. It is not something that you can do a quick clean afterwards and it goes away. It is airborne, and it is also very infectious for 4 days before you even get symptoms. So really challenging area. The numbers in the Midlands, it's too early to say whether they're coming down. They're not as bad as they were, but sometimes you get a peak before the big peak, so it's really hard to say. Health inequalities is really important. The cases that have been in Birmingham and the West Midlands, wide of the Black Country, and Coventry and Warwickshire have been very focused on areas of deprivation where vaccination figures are much lower. So there's been calls to our 7 lowest GP areas, bearing in mind some of them are 85%, so it's not as low as areas of Birmingham. But just a supportive conversation to say, you know, is there anything else you need, anything we can do to increase this, and aware of it's another ask of general practice. There are conversations now starting to happen with, you know, do we need to do anything else around vaccination? So you'll have seen probably on the news that Black Country, Wolverhampton did a pop-up shop in the middle of the city centre, as they did with COVID as well, to try and attract people to get immunisation. But 2 vaccinations is an absolute priority, and all the numbers are about children under 5 because that's what we collect. But that's the key to the door. So it's vaccination all the way. So it's kind of where we're
Liz, thanks, Vanessa. Liz, do you want to add anything to
Just,
that?
I mean, Vanessa said it all, but it's the promoting the MMR.
Yeah.
If you haven't had one dose, and in a sense, we're talking about a long period of time that uptake has been lower than what we would want, and therefore you've got susceptible people at work as well as children and young people. I was heartened to hear only yesterday, in terms of one of the calls to the practices with the lowest uptake, our Health Protection Hub was able to put them in touch with their local school and actually, you know, try and do something between the school and the practice, which is just a sort of partnership working, which is good.
Do you need us to do anything around this table, as it were?
I think taking the message back to individual organisations to promote MMR in your staff, because actually the healthcare workers with 2 vaccinations have got measles, and we think that's, well, the national thought is that perhaps the vaccination's waning by the time you get into your 30s and 40s, whereas with younger children it's much more robust. But if it's not spreading in children, it should spread in adults, so that's the theory. So take that message back, check your vaccination rates amongst your staff, promote it all the way, and have sensible conversations with parents, really.
And primary care to try and increase uptake as much as possible.
I wanted to bring in Julian.
And in the advice, there are also some big impacts on primary care in terms of infection prevention control, and also the extra work that comes into primary care. Part of the advice is that anyone who you suspect could have measles, so you know, a young child with a fever and a rash, anyone with a fever and a rash who's in the unimmunised or partially immunised states needs to be treated in a different way. And in theory, the practices need to assess them. With the latest guidance is they need full PPE, including face visors and 3 face masks, which is something that practices didn't have during COVID and don't have now. And I think it's about the fact that I know those guidelines may change and they may become more practical about how things are done, but there is a big pressure there in primary care and potentially a cost pressure around providing adequate PPE for staff. One of the issues I know has been addressed today through Vanessa sending an email about testing of practice staff, because one is about knowing whether practice staff have actually, most practice staff may not have had 2 measles immunisations, or may not know whether they've had 2 measles immunisations. Looking at my immunisation records on the NHS app, I'm not clear. I've had the rubella and the mumps, but I don't think I've had the measles, so we need serology, and it's about putting in an occupational health system for that. If you're subsequently in contact with someone who has measles and you're unimmunised, you need to and Vanessa probably knows it better, need to be absent from work from day 4 to day 24, is it? Something like that?
Yeah, something around,
So
I think it's 21 days is what I understood. Yeah.
Yeah, so you'd be away from work for 3 weeks. So if you've then potentially got, 1 or 2 clinicians in a practice, or paediatricians in the hospital, even more so, who are absent from work for 21 days. So I think, whilst from a public health point of view and a prevention point of view, the most important thing is clearly the immunisation rates and reinforcing that. I think the practicalities of the guidelines and how we actually manage these children and suspected adult cases in primary care is a big challenge.
So just a question for public health, if you like, and you, Vanessa, and primary care. Is there any kind of mass engagement communication programme that we ought to be offering within STW, or is it covered in other ways?
I mean, it's very much being led by UK HSA.
Yeah.
So there's a centralised, the schools vaccination service.
As a local authority, we've been putting out comms, a lot of comms in terms of schools, early years providers.
You are doing.
We are doing that, but I think it would be helpful for the STW comms team to be working alongside and to reinforce. So we look. So
if we can, that's I suppose what I was looking for. Any gaps.
And they've got the information, sent the information.
Can you pick that up, Simon and Vanessa? Thank you very much indeed. And we'll keep that under surveillance. And don't wait for next meetings if there are things that you need us to consider, please tell us.
Can I ask one other question about something else in the report, which I think also just needs altering? It's the 2.6, which is the independent inquiry into Telford child sexual exploitation. Some of the in the report it says that the NHS actions or the health actions are ready for completion, but then it's not clear that then the comment relates to the 2 that aren't. One which is the fund around sexual health services for public health, and one relates to the trauma-informed approach. So I assume they're the ones that aren't ready for recommendation.
No, that's right.
Yeah, and it's just the wording in the report doesn't read like that.
Okay.
It says there are 3 ready, and then it's got a comma, and then it says the 2. So one is about hearing about that. Obviously that's a very significant issue, but also just to make sure the report reads correctly.
Thank you very much indeed. The Good Governance Institute Governance Review. Again, I assume people have read it. There's been quite a bit of discussion about it outside of the meeting with committee chairs, etc. Simon, there's a clear set of recommendations, and if you're comfortable about me asking people if they're happy with them rather than asking you to introduce the paper, you all right with that?
I am, other than I would want to thank Alison and colleagues for the work that they've done in terms of getting it to this point, and would want the board to recognise that, because I know it's really easy to capture in a paper, but the work behind the scenes to make sense of then the report and put it in place cannot be underestimated. So I just would want to thank Alison in that sense.
And Alison will be delighted to put this to bed, because it has stopped me nagging her every other week about this report, where's this report? Good stuff. So the recommendations, Meredith?
I saw the rationale for staff-related issues to go through the executive group, but it seemed that it felt like there was a risk there that things could be, well, if I say hidden, that's a pejorative expression, but there didn't seem to be any required reporting arrangement from the executive group through to anything. And it just felt important to me that we needed a bit more transparency around that. So I think the terms of reference say it may report to the ICB, but I would have thought we should say will or must. or indeed struck me that the audit committee might be a good one as well. But I just wanted that to be considered.
Simon, are you happy with the use of the word will?
And yes, so yes, and we will agree which committee that best reports through as well. Okay.
Yeah, thank you.
Thank you very much indeed.
Can I ask one more question, really, because it's very
You're on
important.
a roll today, Dr. Povey.
It's just, and it shows I've been reading the papers. But 2.45, which says about the system executive group, it talks about the lack of clarity on membership purpose and how the group fits into the rest of the performance, into the governance structure. I then couldn't quite see any further mention later on in the report about what they're recommending doing with the system executive group. I see what they're doing with the ICB executive group. There's a chart, isn't there? And there's a chart for the ICB committees, but there doesn't seem to be any further comment about what they recommend about the system executive group.
As in the system transformation group or the ICB?
Well, the system executive group.
Just point me to a section.
2.45, 2.4.5, which is page 253 of the pack. And I assume that's the way you meet with the other chief execs. And
are you in the appendices?
In appendices, yes.
So have you read all 390 pages of the appendices as well?
I don't know. I have to admit, I didn't read all that garbage about the specialised commissioning stuff. And there was hundreds of pages of that. I thought, that is... Not even I've got time today to read that.
I'm pleased I've met somebody who's taking that almost as seriously
Simon,
as
do you
I
want
am.
me to answer that? Because I think I know the answer.
So go for it.
Yeah, so the GGI have described the system executive group. That's the group of chief executives that currently meet, but they're not part of any formal decision-making process. What the GGI propose, and which is what I'm suggesting we accept, is that actually that is partially translated into part of the formal governance process as an interim measure. IDC falls away. The majority of what IDC is currently doing passes to the System Transformation Group, which is the chief executives meeting as a formal part of the governance structure. But that's on an interim basis, because obviously there's an assumption that provider collaboratives will move into that space, and that there will be different, governance processes to support that in the future.
Yeah, good. My worry was that was where a lot of the not work is on, where a lot of the sort of combining and collaboration is done is in that group currently. To see that mentioned, then to not see it mentioned again, I thought, well, actually.
So the change in title and where it was picked up elsewhere, it was that bit, Julian.
Yes, that's the pulling out from
Harry as chair
informal.
of IDC.
Yeah, I mean, it makes perfect sense. It's a sort of two-stage approach to get to where you want to get. Makes perfect sense. And I think the point is about what goes there. What goes there is the right stuff, but the problem is it's who goes there that's the problem. And by changing to the system group, you have the right people around the table.
Katrina?
I continue to have a concern that the People Committee is a strategic committee and not an assurance committee. I appreciate the rationale at the moment for some aspects of that, but I'm just wondering if we're missing an opportunity to actually think about the people aspects of it with a much more robust assurance framework than I can currently offer as the chair of a provider under a strategic framework.
So myself and Stacey met on Monday with HR colleagues, and one of the actions from that, Katrina, was for the two of us to pick up a conversation with you to work through exactly that, so that we could come back with the updated, more robust approach in terms of that space.
All right, you can be assured then that I won't fight the solution.
Good. You haven't seen what I'm proposing, but I'm pleased to minute it at that point, Chair. Anyway,
no, but I think we are missing a trick within today's NHS regarding culture, etc., that is not seen as an assurance committee.
That's good stuff, and thanks again, Alison. I'm just riding over your final comments on that, because it sounds like there's a solution in the making and some dialogue which
we're in agreement in terms of that assurance piece as well as the strategy piece.
Okay, thank you very much indeed. Now, the committee reports.
I think I should have the last word.
The committee reports, as is my wont, I'm assuming you've read them all, and unless the committee chairs who are present, that's Trevor and Kathy and Katrina and Harry, more than I thought for a moment. and Meredith, yeah. Unless there are any particular points you want to draw to our attention, given that we've covered a lot of the territory anyway during the course of the meeting, I propose that we note the contents of the various reports. You happy with that, Harry?
Yeah.
Meredith?
Yep.
Happy with that? Katrina?
Yep.
Trevor?
Yes.
And Kathy?
Yes.
Brilliant. Thank you all very much indeed. So, is there any other business? The date and time of the next meeting is currently publicised as the 27th of March, but there's a potential issue with that, which our office is ringing around about that at the moment. So we'll confirm or otherwise that at the moment. And we finished on time. I'm sorry for that going on so long, but actually we discussed some really important issues, and I thought we had some very good, mature discussions about them. So thank you all very much indeed for your contributions, and I'm sorry if I've kept you away from your next appointments. That includes you, Mr. Turner, because you and I and Simon have got... I know. We have another probably brief meeting, but, well, maybe not brief. Okay, thank you very much indeed, everybody.